3 because this is on the list of, it's less difficult than the previous sections, but it is basic, straight information. Okay, chat history has been cleared. We do have Casey Eversley. Is Norma really here?
No, Norma, the account has to be in her name.
Oh, I see. Okay.
She's likely to be at the university longer than any of us. So we're missing 2 online. John Romaine will come back on, and Peggy Fowler, who's a member of this iteration, they'll eventually come on.
Okay. Hi, Casey. How you doing this morning? Casey is typing. Very well. Glad to hear it.
I have a question,
Yes.
and it's related to pharmacology.
Okay.
Where do you go for, with like getting people off of medications? Like you go to, the websites and it'll tell you how to start somebody on a medication, what dosing to, titrate them up to, but where do you go the other way? That like, how do you, like, if someone's on a high dose of a med, is there some consistent place that you can go to see how fast and safely you can take them off of that?
You remember the old PDR? The old PDR is a compilation of the manufacturer's drug information that includes switching information and discontinuation information. So you can actually go to, if you look up aripiprazole, and go to the website for the company that produces it, and they list everything that is in the article in the PDR about aripiprazole, including all the drug trials, and then counterindications, interactions, how to start it, how to switch to the most common medications that you might be switched to or from, how to switch from others, and discontinuation, and warnings around discontinuation. So that's all spelled out in that long form. So I haven't suggested this to this group. I don't know if any of you ever gone to, let's just say, the website for aripiprazole, Abilify, and read the whole darn thing, because it has FDA information. It talks about the trials, the trials for the approval of the process, and it has detailed information about switching and discontinuation. So if somebody says, well, I don't know how do I switch from lithium or from Abilify to a lithium, that should be on the website. And how do you discontinue? It should be on the website. There are quick and dirties for how to discontinue some. And when it comes to more detailed titration protocols for benzodiazepines, there are a number of those. But this is where, this is beyond the basic psychopharmacology education. It's what you learn when you're out there and you want to take somebody off and you say, well, nobody told me how to do this. So you can go to Up to Date as a resource. You can go to the ACP Peer, will give you insight into how to do titration protocols. You can talk to a clinical pharmacist, because they'd be able to get you references for that. But the basic drug information, the most solid, where Hippocrates gets its stuff, is from the PDR, from that published information about the drug. It's on the manufacturer's website. And it should have black box warnings. It will have any detail with regard to drug. Any other questions before? That's a good question. Thank you. That prompted me to folks said, well, yeah, that's, that big fat PDR thing. And I think you used to be able to get a volume that just had the psychotropics, the PDR stuff for psychotropics.
It just seems like an omission error or something to me that, like, in these sites that I go to a lot about black box warnings, side effects, all these other bits of information about meds I might want to start, doesn't have anything about getting them back off. It just seems like an oversight.
Well, typically, a lot a majority of patients go off medications without instruction, voluntarily, and sometimes surreptitiously and voluntarily. Mostly surreptitiously and voluntarily. Okay. This refers to the interactions of drugs with biophysiological systems, encompasses pharmacokinetics and pharmacodynamics, pharmacogenetics, and the epidemiology of various medications such as psychotropics, adjunctive agents, and other medications used in the practice of medicine, as well as substances of abuse, OTCs, and food and dietary supplements. The influence of cultural ethnic factors, environmental factors, and responses of special populations are considered. Casey says no green chili where Casey is. That's a sad commentary on Casey's life. That's sad news. We have to learn very deep information about roughly 100 medications. A clinical pharmacist has that depth of knowledge about 2,500 medications. And we focus on the psychopharmacological agents, but you're going to need to know when you practice about a lot more medications than the psychotropic agents, because a lot of patients, it's a very rare patient who's not on another prescribed medication. And the typical 65-year-old is on 4 prescribed. The typical 80-year-old is on 8 prescribed medications. And so knowing the most common classes, interactions with antibiotics, which many times can be short-term, but with the chronic meds, the antihypertensives, the anti-cholesterol medications, the medications for diabetes, these more common conditions, the analgesics for pain, those are medications that you are going to be dealing with regularity, so knowing something about those is also important. There won't be a whole lot of that on the PEP, but that's why you only really learn to manage medications when you're out there treating a patient at a time. And the difference between traditional medical education and traditional psychologist education is traditional medical education is an apprenticeship. Now, medical education is moving away from classroom didactics, and it's all treating patients under supervision, beginning to take a role in the treatment of patients, and increasing responsibility for the care of patients, and learning medicine one patient at a time. And our instruction is still, you're just finishing the didactic portion of this. You'll really learn it when you can hang this information on individual patients. It will become a whole lot more memorable to you when you do that. And it takes a while to get confidence. Remember, there's that 10,000 hours to feel expert. Well, it's probably the case that until you have prescribed for 10,000 hours, you're not going to feel like you have expertise in managing psychotropic medications. And so you shouldn't be feeling confident now. I had a colleague who was taking the psychopharmacology classes, and she was despairing that she just didn't feel like she was learning enough. She said, well, I don't feel confident enough to manage medications. And I said, well, you shouldn't feel confident enough to manage them because you're not at that point in this training process. You will get there, but you won't really get over that hump until you're actually doing it. And then once you successfully treat one patient, then you'll have a little self-experience success, and then the next patient, and gradually you build up this experience base. In the same way that you don't know how much you really know as psychologists. And sometimes other people give you a mirror that allows you to see yourself and what you do in a way that you don't see yourself. And the mirror for me in my practice here is that I can meet somebody and pattern match and assess them pretty quickly. And you know how quickly you can really get the gist of what's going on with somebody. And that looks like voodoo magic to the physicians you work with, who are at least young physicians, that you can that quickly sort of evaluate and verify something about the psychological functioning of a patient, and you do that without really knowing that. I am more valuable to the healthcare community in Las Cruces because I can diagnose and do that quickly and can do differential diagnoses very quickly than I am as a prescriber. I mean, I'm neck deep in people who can write scripts. What they want to know is which medication to prescribe. And that's based on the differential diagnosis and figuring out what the target symptoms are to treat. And so I'm utilized for that more than I am for, once I place them, well then we'll prescribe this. Well, they may ask me a little bit of advice on which medication or something. But it's more, come in and tell me what's going on with this patient. Okay, so back to this is straight pharmacology. Now remember, pharmacokinetics is the movement of drugs, absorption, metabolism, distribution, metabolism, and excretion. It's that physical movement of the chemicals is pharmacokinetics. Pharmacodynamics is, okay, when it gets to the site of action, what does it do? And a dynamic effect of a medication is everything it does, including what we class as side effects, which are just effects of medications that we don't happen to like. But medications only have effects. They don't have side effects. We just subcategorize some of the effects as side effects. Okay, knowing something about the classes of medications, and you know this, knowledge of biological factors affecting pharmacokinetics and pharmacodynamics. We're going to review pharmacokinetics first and reserve the study of pharmacodynamics for the next chapter. I mentioned what that is already. So we're interested in the absorption, the distribution, the metabolism, and the elimination of these drugs. By the way, the acronym for method of action you probably figured out already is the MOA. So somebody says, well, what's the MOA of that drug? Then they're asking, what is the proposed mechanism for how it works? And remember, we don't really know how any of these medications work. We have theories about it. And the theories seem to hold up over time, but then they're dispensed with when there have been maybe 50 to 70 generations of theories about how lithium works. By the way, your children are just charming.
Oh, thank you.
That was so fun
I had
to
my own
see
cheer.
how excited they were. That was so cool. Yeah, that's great. Pharmacokinetics. How quickly it's absorbed or how quickly it gets into the system is affected by the route of administration, whether it's parenteral, beneath the skin, or inside the body, oral, rectal, transdermal, sublingual, or inhalants, or inhalation. Okay? And we have examples of forms of psychotropics in all of those categories. Most of what we do is just oral administration. We do IM, occasionally IV, occasionally subcutaneous, which is SC. Transdermal, we have patches. We have dissolved below the tongue, disc melt. You know, you can get that Xanax into your system quickest if you just put it under your tongue and dissolve it. And so for people who are going to use it to stave off a panic attack, that's what you can suggest they do, and it'll get into their system very quickly. Time course of drug distribution and elimination. Drug half-life. In this case, there are a number of different half-lives, just like there's 2 different or more first pass categories. There is more than one kind of half-life. And there's a half-life for distribution, there's a half-life for elimination, drug half-life, metabolic half-life, elimination half-life, accumulation rates, and the steady state achieved. For most of our medications, we're going to want to achieve a steady state. Give me an example of a medication where we don't want a steady state. For an SSRI, you want to achieve a steady state. You want to get a steady blood level. So you want to achieve a steady state. Give me an example of a medication that you're going to prescribe where you don't want a steady state. You really don't want it.
Methylphenidate.
Yeah, stimulants. You want them to come on, do function while the person needs to function, and wear off before it keeps the person from being able to eat and sleep. Okay, give me another example where you don't want it to achieve steady state.
Sleep medication.
There you go. Okay. So thinking about the half-life then, you may be interested in a long half-life or a short half-life, especially because you're trying to figure out, do I want to achieve a steady state or do I want a time-limited effect in this medication? We do primarily the oral administrations, and most drugs are absorbed through diffusion. So it is that you take the chemical in, and it has a monovalent bond, and it dissolves, and the one form of it can be absorbed, diffused across the bilipid layer of the GI tract. And so it just passively diffuses across. And then as that portion of that drug that dissociated diffuses across, then more of the drug dissociates. So it's a passive diffusion across the GI tract. However, there are other ways like filtration, bulk flow, endocytosis, ion pairing and then diffusion, and facilitated or active transport. There's some drugs that the GI system actually latches onto it and has transporters, and it's usually capitalizing on or piggybacking on a transporter system that is already there in the GI system. Drugs are absorbed through the GI system if they're taken orally, but not subcutaneously. Remember, we're talking about those that are taken orally or rectally, absorbed through the GI system, through the wall of the GI tract. Remember, our bodies, we're a tube. I mean, we have skin on the outside and we have skin on the inside, and we have a continuous skin on the outside down to the end, and we have continuous skin on the inside down to the end. So we are just a very long tube. Now it's wrapped around inside of us, but we are a tube from the mouth to the rectum. And that whole lining there is a bilipid layer. There's some spots where it's more permeable than others, and diffusion can happen. And the environment inside that tube changes. And if we take the medication in, then the environment inside the tube that it's passing down changes from acid to base. But it is a tube, and that medication can be absorbed and diffuse across that bilipid layer the whole way down. But most of it happens pretty high up. The pH changes from acid to base. Most drugs administered orally, 75% are absorbed within 2 to 3 hours. Now, where exactly, whether they're absorbed very quickly or whether they are absorbed more slowly, depends on the dissociation constant. relative to the acidity of the medication and the acidity versus basic environment in the GI tract. So the dissociation constant of the medication is affected by its acidity, where in that 3-hour, 2-hour process it is absorbed most rapidly, depends as the kind that you put in your stomach with that medication, or the lump of medication itself, where it is, just how far down it is. But no matter how acid or non-acid the medication is, no matter how acidic your stomach environment is versus you took a buffer, you took something to buffer your stomach so it's more basic and so it's not as acid. No matter what you do with that, 75% of it is absorbed within 2 to 3 hours. However, where it is then varies based on those parameters. So, the half-life of distribution is referred to, means it's that how long it takes to reduce the initial peak level in the blood by 50%. The elimination half-life is how long does it take for 50% of the drug in the bloodstream to be eliminated through hepatic metabolism. 98.4% of a drug is eliminated by 6 elimination half-lives. So you want to know, okay, how long is it going to be before you stop this drug now? How long is it going to be before it's gone? It's 6 elimination half-lives. So if you just want to know, on average, how long does it take? If I want to start another medication that can interact with this one, and I want absolutely no chance there's going to be an interaction, then I look up the elimination half-life, multiply times 6, and that's how long I say the person needs to wait before they take the dose of the new medication that might interact with it. Okay? A steady state of blood level concentrations usually is achieved by regular dosing of the drug at 6 elimination half-lives. So now if you're trying to get steady state of the drug, you're going to get a steady state of the drug once you give the person 6 evenly spaced doses. Okay? But if you space those doses too far apart, the steady state is going to look like a scalloped pattern if you follow their available blood level. If you want a steady state that is relatively like a plateau and stable, then you time the next dose at 1 elimination half-life. So if you do that, once the person has taken 6 doses, spaced at 1 elimination half-life, they will then have a plateau of bioavailable medication in their bloodstream that is relatively flat across the top. How does the pharmacological community decide how often you should take a medication? Well, by looking at the elimination half-life and having you take it at a frequency that will permit an achievement of a steady state that is a relatively unscalloped plateau. And so if you wonder, well, why do you take this drug twice a day and this one 3 and that one 1 and this one every other day? Well, it's because if you're trying to achieve a steady state, you just look at the elimination half-life and how often do I have to take have this person take this to achieve that? And that's how you set the dosing schedule. Now, calculated into that is the fact that people run on a diurnal schedule, so you're not going to get up in the middle of the night unless it's absolutely critical. And in the hospital, they dose people around the clock sometimes with critical medications, but real people are not going to wake up in the middle of the night and take a chronic medication. So you sort of adjust for the fact that there's an 8-hour period when they're probably not going to take the medication. But that's basically, that's the data you use to decide how often the medication is dosed, okay? Psychoactive drugs are usually dosed so that a steady state's achieved. Each subsequent dose is administered at about one elimination half-life interval, and steady state occurs after about 6 doses. Now that doesn't mean it starts having a dynamic effect, because essentially you need a steady state before an SSRI is going to start working dynamically in a way that reflects that steady state bioavailable level of the SSRI. So once you give them 6 doses, then it's 14 days before you'll see fully how much a person's going to respond to that dose of the medication. Okay? Since a majority of the drug is gone in 6 half-lives, after 6 doses are taken, the amount of the drug still present in the body is the additive contribution of 6 doses, with the most recent dose contributing the most. So just before you take your 7th dose, there is 1/2 of the last dose you took, 1/4 of the prior dose, 1/8 of the prior dose, 1/16, 1/32, okay? And add those up, and that's the plateau of bioavailable medication in your system, okay? Blood concentrations correlate well with concentrations at the site of action. That doesn't mean they correlate well with the therapeutic or dynamic effect. But if you're wondering, okay, how well, now I've got to cross the blood-brain barrier with this stuff to get it into the person's brain if the site of action is the brain. And so how well does the amount that's in their bloodstream correlate with how much is gotten through the capillaries in the brain and into the interstitial space between those neurons so it can swim in there and block reuptake? Well, it's well correlated. So the assumption is you've got about as much in that interstitial fluid as you do in the bloodstream. So it's available at the site of action. And you usually have to hit a threshold for any medication for it to begin to work. Some medications' effects are completely dose dependent. And that means that the lower the dose, less effect, larger dose, bigger effect. But in fact, what this is saying is it's not really dose dependent. To start seeing effect, you have to hit a threshold before you begin to see an effect with many medications. Most drugs are not monitored for serum concentrations. We've talked about that before. Concentrations are not well correlated with therapeutic action. Well, we know about lithium, valproic acid, and carbamazepine. Monitoring is useful for the evaluation of patient compliance and a maximization of effectiveness by raising serum levels slowly. So, in fact, if you have somebody, you don't know how well their body's going to handle this medication, and you're worried about going toxic, or an elderly person with compromised hepatic or kidney function, then if you think they really need the medication, then you can draw serum levels. Start at a low dose, draw serum levels, start. And so you can then get from a clinical psychopharmacologist or a clinical pharmacist. They can tell you, they can do the research, they got the data on what would the blood level be typically in a patient on average who is going toxic on this medication. And then you bring the serum level up slowly beneath that toxic level, and so you can adjust the dose that way. It's very seldom that we need to do that, but it is done. I mean, the longer you're at this, the more patients you see, and if you're in a hospital practice, you may end up having to conspire with a team, including clinical pharmacists, to do that kind of a titration, careful, science-based type titration. But even the patient I have on an antidepressant who's on kidney dialysis, we don't have to do that, because the whole point of dialysis is that it dialyzes and removes the metabolites of the medication. So as long as the patient's functioning, doing well, and being monitored while they're on renal dialysis, then you can put a medication into them. And a lot of renal dialysis patients are on antidepressants. And they're depressed because dialysis is a 3-time time sink and a lousy way to live. And it's immobilizing and alienates people from their social environment and that kind of thing. So again, primarily oral administration. Now, I talked a little bit about what affects absorption. Remember, it depends on the rate of dissolution. How quickly does this medication dissolve in the chyme, a lump of whatever is moving down through the GI tract? The interaction of the drug's pH and the pH environment of the GI system. And the drug's form, is it in an ionized or a non-ionized form? And the molecular size of the drug, how big the molecule is, and the percent of first-pass gastric metabolism. Most drugs are weak acids or weak bases. Drugs must dissociate in order to be absorbed. So they've got to be broken down. They need to dissociate after they dissolve into the ionized and non-ionized forms, because non-ionized forms of the drugs must be present in order to be absorbed through the diffusion process. Remember those ionized forms? Those are the ones with the electrical valence that don't go through the bilipid layer. So you have to have the non-ionized form to dissolve through the bilipid layer. The pKa, which is the dissociation constant of the drug, indicates the pH at which 50% will be broken down or dissociated. You want it to dissociate. You'd like to have 50% of it dissociated, because the half that is non-ionized can then be absorbed. So you want it to dissociate. So you want the environment and the pH of the environment and the pH of the drug to match in a way that there's 50% dissociation, and then the non-ionized form gets absorbed through the GI tract. The lower the pKa, dissociation constant, the greater the degree of ionization. Suppressing ionization, making it more lipophilic, increases the pKa. The two interchangeable forms, the ionized and non-ionized forms, are found in the GI tract, and only the non-ionized form can be absorbed through that diffusion process. And remember, the amount of the non-ionized form is affected by the drug being a weak acid or a weak base, whether the environment is more acid or base, and the drug's pKa. Remember, the GI tract starts acid and becomes more base. Weak acids are best absorbed because drugs with pKa's below 7 ionize less. So if the acidity of the drug is closer to the acidity of the environment, they're less ionized, and so therefore it can be absorbed better. So that close match means that it doesn't dissociate as much, and so there's more non-ionized form there.
Can I ask a question?
Yes.
How does does gut flora affect the absorption rates?
It doesn't affect this process.
Okay.
Gut flora may produce byproducts and may participate actually in the first pass metabolism, but it's not affecting this. The main factors here, the big story, is the acidity of the environment and the acidity of the drug and the dissociation constant of the drug. You get absorption even when there's only a small percentage of the drug is non-ionized. Remember I said these drugs are constructed so most of it, 75%, is absorbed within 2 to 3 hours. How close the acidity of the medication is to the acidity of the environment just south of the stomach determines how quickly it gets absorbed and how fast. And so if the drug, in order to form enough non-ionized form of it to be absorbed, if it takes longer for it, if it has to move down to a more base environment farther, then that slows down the absorption, but it still gets 75% of it by 2 to 3 hours.
So could you argue that rectally administered medication should be more based to increase the absorption rate?
Yeah, that makes rational sense to me, but I don't know how acid versus, I think rectally we're primarily base, but I don't know what they do with calculating dissociation constants and pKa's in rectally formed medications. As non-ionized forms are absorbed, more of the drug becomes non-ionized, preserving the percent of ionized and non-ionized on one side of the membrane. The rate of absorption is affected by the percent of the drug available in the non-ionized form, and the rate of absorption is therefore greater when the drug is a weak acid in a mildly acid environment. Drug solute is transported across the bilipid membrane inside the GI tract, again by diffusion. But the ones that aren't in that form, aren't the weak acid, and therefore form a non-ionized, when they dissolve and dissociate, form a non-ionized form, have to be taken in by another means, by filtration and bulk flow, or by endocytosis, ion transport pair. And what would that be? Ion pair transport? Well, there would be an ion in the GI tract that would form a covalent bond with the dissociated part of the medication, and that new chemical would be non-ionized, and so it could be absorbed. Endocytosis, ion pair transport, active transport. Ion trapping refers to the pH of the GI tract and the pH of the blood and the pKa of the drug. Drugs with a pKa below 6 tend to concentrate in the blood. Drugs that are bases with a pKa greater than 8 tend to concentrate in the GI tract. So once, remember, the blood itself is an acid environment. And so it has an acid-base value also. And so if a drug gets into the bloodstream, and therefore the environment of the bloodstream is such that very little of the drug dissociates, then it can't get back across into the GI tract. But think that this is it's a passive diffusion process for most of these drugs. And so we think of the drug being absorbed into the GI tract, but the drug can come right back out into the GI tract from the bloodstream, with the exception that the bloodstream has a different pH. And so now the drug is going to be kept in the bloodstream because it has a different pH. Otherwise, it would just, swim right back out. And all drugs do, the non-ionized form of the drug that's in the bloodstream will pass right back out into the GI tract because that is a semi-permeable membrane, and the non-ionized form of the drug that is a small enough molecule can diffuse right back through it the other direction. Drugs that concentrate in the GI tract are more likely to be eliminated in bulk. For most drugs administered orally, again, 75% are absorbed within 2 to 3 hours. This rate of absorption is due to the ion trapping of the drug solutes in the blood. In other words, it gets to be an ionized form in the blood, so now it's a bilipid layer, so it can't diffuse back out into the bloodstream, into the GI tract. Distribution. Once it gets in there, how long does it take for your blood to circulate one time? One time. Blood circulates one time, how long? You give me an IV drug, how long does it take for it to circulate?
Must be a minute since the second bullet.
1 minute.
Wow.
Read the second bullet. Your blood circulates one full time, 1 minute. So you give an IV, and that's going to hit the brain at full force in 1 minute. Okay? Ionized and non-ionized forms of the drug are distributed fairly equally, except in the brain and across the placenta. And that's due to the tight gap junctions. Now remember, we construct our drugs so that they will pass the placenta and get into the baby, to get into the fetus. We construct our drugs on purpose so they will get into the fetus inadvertently, because we're constructing them to get into the brain. And it's the same barrier, is the placental barrier and the blood-brain barrier have the same mechanism of creating the barrier. And if you look at that tissue, there are very small holes in the wall of those capillaries, in the brain and in the placenta. Now you have blood pressure, high blood pressure long enough, and they'll get leaky. Those holes will get larger, and the capillaries will get incompetent, and that's how it's much easier to get. You have a history of cardiovascular illness with hypertension, that's how it's easier to get a brain infection when you get old and have chronic hypertension than it is when you're young, because those beasties can, if they circulate in your blood, can get into your brain. These tight gap junctions allow only lipid-soluble molecules to diffuse passively, and they repel ionized molecules. Capillary walls are quite permeable except in the CNS and in the placenta. Factors that affect the drug distribution. First pass metabolism, the lipid solubility of the drug, plasma protein binding, and active and passive transport. Now this is distribution. So this is once it's in, what affects the distribution. First pass metabolism, first we can have the deactivation by enzymes in the GI tract, which biotransforms medication. And basically, and biodegrades it. And in the blood, where a majority leaving the GI tract goes right into the liver. majority of drug molecules metabolize before they can become bioavailable. Interaction effects are both pharmacodynamic and pharmacokinetic. Pharmacodynamic interactions, defined as the response to the drug is modified by a second drug or substance. So we have receptor interactions. When two drugs or other substances interact at the same receptor, they can be antagonistic, one can block the other, they can be additive, or they can be synergistic, so they can create an amplification. And then there are non-receptor interactions, when two drugs have additive or opposite effects in the body, but by different mechanisms. Concurrent exposure to two drugs, other substances, may result in altered absorption, distribution, metabolism, and excretion. With regard to pharmacokinetic, this is the movement of the drugs, interactions, the most common are phase 1. That is, phase 1 is hepatic, and it refers to the inhibition or induction of those enzymes in the liver. And conjugation, and you remember conjugation is adding something to the molecule that makes it eliminatable and may or may not be bioactive with regard to a dynamic effect. By the way, after phase 1 metabolism, a metabolite may still be bioactive, also have a dynamic effect. So for instance, with fluoxetine, after phase 1 metabolism, the first major metabolite is also bioactive. It also acts as an SSRI. And with regard to pharmacokinetics, changes in GI absorption and renal and hepatic elimination, including the P-glycoprotein activation. Changes in metabolism. The best studied pathway is this isoenzyme system. CYP P450-3A4 is the most common pathway, accounting for the metabolism of 50% of all medications that go through the CYP system. Other pathways are flavin-containing monooxygenase, FMO, and epoxide hydroxylase, microsomal MEH, soluble SEH. So here is the percents of oral administered drugs that are catalyzed by the various CYP systems. UDP glucuronosulfotransferases, UGT. I don't say that very often. I use that in common conversation all the time. I can't understand why I stumble over it so often. Phase 2 are a set of enzymes responsible for converting chemicals into their polar entities, allowing for more easy excretion. Remember, if you want to get something out of the kidneys, you make it water soluble. If you want to get it out of the GI tract, you make it fat soluble. So notice what's happening. To get the medication in, You're trying to get a non-ionized, fat-soluble, non-water-soluble form of the drug to absorb it into the GI tract. To get it out, you got to chop it up, make it water-soluble so it can be excreted through the kidneys. Okay? Other pathways are sulfontransferases, and I'm not going to try to pronounce glutathione S transferases or N-acetyltransferases or methyltransferases, because those are hard to say too. Enzyme systems metabolize the drugs in the liver. They're biotransformed into metabolites which may be pharmacologically active, usually less lipid-soluble and more water-soluble, and are less likely to be reabsorbed and can be more likely excreted. Now, the P-glycoprotein pathway, the PGP, inhibition of PGP allows for greater GI absorption and a decrease in excretion into the biliary tree or the kidney. And there's a strong correlation between which medications induce or inhibit the PGP system and those that induce or inhibit the CYP3A4 system. Types of metabolism in the liver. The most common is oxidative reactions, and hydroxylation involves inserting a hydroxyl radical into the molecule. Enzymes for this are found in the endoplasmic reticulum and of hepatocytes and elsewhere. And then there are hydrolytic reactions, those that cleave ester bonds. And finally, enzymes that are found outside the endoplasmic reticulum. And conjugation, which is products of the above reactions can be combined with other molecules in the body, further transforming them into excretable forms. Tolerance. The concept of hepatic tolerance. CYP450 enzymes become more efficient. They're induced. So the liver can simply more rapidly metabolize that drug. Now that's hepatic tolerance. Remember, there's also the neuronal tolerance, which is upregulation or downregulation. So you become more tolerant to a drug, its effect, when you downregulate, meaning there are fewer receptors, so that drug, the impact of the medication or the drug is dulled. So there are a number of different kinds of tolerance, but this is hepatic tolerance, and that is induction of the CYP system. I only looked your direction when you were down on the floor, and I saw, oh my goodness, what has happened here? He's hiding. Okay. Induction is increasing the production of the enzyme. Inhibition is decreasing the production of the enzyme, called metabolic sensitization. So there are drugs that actually inhibit their own metabolism. Give me an example of one of our medications that is famous for inhibiting its own metabolism in a very pronounced way. I'll give you a clue, narrow it for you. It is an antidepressant. It inhibits its own metabolism.
Multiple choice.
I'll give you a further clue. It was the first of its class to effectively treat obsessive compulsive disorder. Fluvoxamine. And the reason it is the first of its class was because it inhibits its own metabolism. Chronic dosing of it meant that the bioavailable level of fluvoxamine went up higher and higher and higher. And what we now know is you have to have very high doses of SSRIs to have an impact on OCD. And so the reason it popped up as the first one is because it inhibits its own metabolism. But if it inhibits its own metabolism, what does that make your patient more vulnerable to? Serotonin syndrome. I gave a lecture on psychopharmacology, and there was a psychiatrist in the audience. So I asked him if he prescribes Luvox, and he said, "Well, yeah, he does. I don't, but he does." He said he has used it for years and is pretty comfortable with using it. But he's also familiar with that aspect of the medication, to watch for that and take that into consideration. So it's an effective medication, but I'm just a nervous, most prescribing psychologists are nervous sorts like me. So we tend to play, here's the boundary. We stay way over here, I don't want to even get near the edge. I'm going to stay by the car rather than going out and looking over the edge of the Grand Canyon. I'll be here when you folks are done looking down that canyon. Cytochrome P450. Some medications induce the same enzymes that metabolize them. So now here's why you will see patients who are taking carbamazepine on big honkin' whopping doses of stuff that if you gave it acutely to someone the first time, they would be in serious trouble. But over time, to get the therapeutic effect, the dosage is ramped up to a pretty high level. And here's where you can check the bioavailable, the serum level of the medication. And the reason for that is, remember, first pass hepatic metabolism. If you've induced the metabolism of the drug, when you do a serum level, it's going to what has gotten, how much of it's left after it got through the liver. And so you're checking the bioavailable level post-hepatic first-pass metabolism. So you will really be able to tell something about how much is at the site of action and won't be as confused about the relationship between how much the patient's taking and how the reaction is to the medication. Some medications inhibit the same enzymes we talked about that I gave the example of Luvox. Ethnic and gender differences. There are in polymorphisms, ethnic and gender differences. And remember, this is somewhat old data, but the PEP is old data. Differences in cytochrome P450 isoenzymes and drug metabolism. If you want the straight dope, you can get from the drug manufacturer, from the PDR, from a pharmacist. And websites available for specific purpose like Hippocrates and Tarascon. Everybody has Hippocrates on their cell phones, don't you? Everyone here have it? Yes?
Yes.
Okay, good.
What's Tarascon?
That's an old Hippocrates. I think it's still out there. It's an alternative.
I use Medscape too. Medscape's pretty good. It's on your phone or on
Yeah, it's pretty good. Psychodynamic. This is pharmacodynamics, is the study of how drugs affect the body. Bridges directly to clinical pharmacotherapeutics, which is the use of the drug's dynamic effect to produce the therapeutic effect. It's the study of the method of action. Action at the molecular cellular level examines the manner in which drugs affect cells at the site of action. The most common MOA is to affect neurotransmission rates. The most common manner is to affect synaptic transmission, alteration in the production of a neurotransmitter, interference with storage, interaction with pre- or postsynaptic receptors, interference with the uptake or reuptake of the neurotransmitter, or alteration or destruction of the neurotransmitter, changing the or altering the destruction of the neurotransmitter. So those are the things our meds do. They're going to affect transmission, neurotransmission, most of them. They're either altering the production, interfering with the storage, interacting with the pre- or postsynaptic receptors in a way that alters neurotransmission, interfering with the uptake or reuptake of the neurotransmitter, or altering or the destruction of the neurotransmitter. So that's an MAOI, isn't it? And the second and last one is a selective serotonin or serotonin norepinephrine or dopamine reuptake inhibitor. Synaptic transmission alteration is the most common MOA. Drug types: agonists facilitate transmission, antagonists inhibit or block it. The impact can be direct. So a drug binds directly to sites on receptors that the neurotransmitter binds to, so it's competitive. Indirect. So what you're doing in that case is plugging in either to the postsynaptic neuron and saying, well, since there are serotonin receptors on that postsynaptic neuron, what I'm going to do is just put a bunch of extra serotonin in there in that synaptic trap, and so it's going to fire that postsynaptic neuron much more easily. The presynaptic neuron doesn't have to squirt out as much. Okay? And that's how you used to think serotonergic agents worked, was that you were blocking reuptake, so that meant there was more serotonin, so it was firing that postsynaptic neuron. But that's not really therapeutic action. The therapeutic action is the down-regulation of the off switch, which I explained to you the last time I talked with you. Drugs binding is determined by the affinity or the goodness of fit of the molecules and the specificity, the selectivity of the drug molecule for a specific receptor. Now, if there's only one kind of serotonin molecule, is there more than one kind of serotonin receptor? Naturally occurring serotonin transmission. Naturally occurring means you squirt out serotonin, it destabilizes, plugs into receptors on the postsynaptic neuron, and makes it fire. There's only one kind of serotonin to squirt out. And there are serotonin receptors on the postsynaptic neuron. But is there more than one kind of serotonin receptor on postsynaptic neurons? Nature doesn't permit the serotonin the presynaptic neuron squirts out to discriminate between those kinds of serotonin receptors. But your pharmacologist, your researcher, figured out that there are different kinds. And so your researcher has created medications that will discriminate and only plug into one kind versus another kind. So remember when we're talking about D1, D2, D3, D4, D5, there's only one kind of dopamine. And if you flood the brain with dopamine, it plugs into all of the dopamine. If your naturally occurring dopamine squirts out, it goes everywhere dopamine can go and plugs into all the dopamine receptors.
Like a master key.
Yeah, it just plugs in. Naturally occurring dopamine is one kind of dopamine, but researchers have figured out, there are different kinds of receptors at different locations. The naturally occurring dopamine doesn't discriminate, But we can create a drug that will discriminate and only plug into one kind, because that one kind of receptor is in one system and not another system in the brain. And so they're fine-tuning the drugs to exploit the differences in receptors, even though naturally occurring dopamine doesn't do that. But if you just give somebody, get dopamine into their system and into their brain, it's going to plug in indiscriminately into all of the receptors. Okay? Am I making sense? You knew that already, right?
No.
Okay. All right. So that's why there's D1, D2, D3, D4, but there's only one kind of dopamine. And as we learn how the brain works, we discover that in various regions, that neurotransmitter that squirts out and goes everywhere plugs in to all dopamine receptors. But you can create a chemical that will only have a good fit for one kind of dopamine receptor. And so the affinity or the goodness of fit of the molecules is one way that they create the molecules that discriminate. With regard to pharmacodynamics, the drugs affect both pre- and postsynaptic receptors. The presynaptic receptors are the autoreceptors. They're located on the axon terminal, photon or cell body. They regulate neurotransmitter release directly or indirectly when the same neurotransmitter is present. So that's the off switch. They swim around. The autoreceptor is, I am a neuron. I'm a presynaptic neuron. Here's a synapse. Here is my autoreceptor. I'm going to squirt serotonin out here. Its main job is to go over here and fire that neuron, but it squirts out, and some of it, it's floating around the interstitial fluid, and it just comes back around, plugs into this off switch, which is a serotonin receptor, and stops this neuron from firing. And then heteroreceptors, different neurotransmitters bind to adjacent receptors and affect neurotransmission. GABA receptors are like that they are modulating the firing rates. They inhibit firing because GABA goes into the GABA receptor and it modulates the firing rate of the neuron. The binding of drugs to receptors and other chemical sites. Ionic and therefore reversible as opposed to covalent. Once you have created a covalent bond, it takes dynamite to break that bond. So we're looking for univalent or ionic bonding. The covalent bonding example is the MAOIs, the irreversible monoamine oxidase inhibitors. They latch on with a covalent bond to the molecule of the monoamine oxidase and take it permanently offline. So it is in the natural recycling process of the body, it is eventually broken down and replaced by a fresh molecule of monoamine oxidase that doesn't have that inhibitor latched onto it, so that it can then break down all of the monoamines. And the strength of ionic attachments is determined by the relative fit of the molecule to the receptor. So two molecules that are slightly different, both can plug into a serotonin receptor. One of them has a better goodness of fit. There's going to be a higher, that molecule is going to be plugging in at a differentially higher rate. And when it comes to the protein binding, some of what determines which medication that is protein bound wins in glomming onto the blood proteins, the albumin, depends on the goodness of fit of that ionic bond. Dose response curves relate to the impact of changing levels of dosages of medication to the degree of activity. And they quantify drug receptor interactions, and there are both graded and quantile. Knowledge of absorption, implications, delayed release preparations, rate of absorption after oral dosing or parenteral injection, area under the curve, and timing with food intake. Those are things that we've covered a little bit of that, but that's what the APA says you need to know about. And knowledge of distribution, plasma protein binding, influence of lipofacility. Remember what lipofacility is. And this lipophilic is more likely to be able to get through that bilipid layer. And knowledge of metabolism, drug metabolism, understanding the substrates and inhibitors, we've talked about that. Other enzymes outside of the liver, we've talked about that. And knowledge of excretion. Some topics there are renal filtration rates and clearance of drugs. Knowledge of the importance of biological half-life in determining steady state, dosing schedules and accumulation. We've talked about that stuff. Knowledge of drug properties and characteristics. Here are some topics that we'll address now. Therapeutic index, therapeutic blood levels and prescription doses, potency, bioavailability, efficacy, cognitive and behavioral manifestations of toxicity and dose-response relationships. And knowledge of types of drugs and other agents interacting with receptors. We've talked about that stuff. And knowledge of drug-induced cellular adaptation, cellular signaling, ion channels, second messengers, neurotransmitter release sensitivity, and supersensitivity. Knowledge of drug effects on genetic expression, downregulation. Remember, the downregulation and upregulation are the genes within the neuron reacting to the environment of the neuron and creating or destroying receptors and altering, therefore, the sensitivity of the neuron to the environment. Knowledge of these things, knowledge of mechanisms of action, knowledge of theoretical relationships thought to exist between neurotransmitter systems and psychopathological conditions based on known mechanisms of action in clinical observations. Examples they give are serotonin depression, dopamine in psychosis, and substance abuse. And knowledge of drug and drug-food interactions for a range of medications. Drug previously addressed, drug-food previously addressed, also a little bit. Remember, tyramine is the issue related to MAOs, and grapefruit juice is an inhibitor, and so drinking grapefruit juice will actually raise the blood level of a number of medications that are metabolized by I believe it's the 3A4 system. Knowledge of drug-induced disease, dysfunction, and adverse reactions. So here we're going to start back through some of those topics to pick up ones that we haven't touched yet. So the first important topic here is the therapeutic index. The second is the certain safety margin. And before I do that, I'm going to give you a 15-minute break. Actually, I'm going to give myself a 15-minute break. You can do whatever you want. The therapeutic index is the dosage at which the first organism, 50% of the organisms taking the medication die, divided by the dosage at which 50% of the organism show a therapeutic effect. Now, this is done not with human beings. This is, of course, done with human analogs. And yes, you really can see therapeutic effects in the human analog animals. And a value of 5 or greater is preferred. So essentially, you want the dosage for a half that is a fatal dosage to be 5 times as high as the dosage at which you see a therapeutic effect. So that's the therapeutic index. I have been asked, well, is there a chart somewhere that lists the therapeutic index for every psychopharmacological agent? No, but you can compose one by looking at the PDR and getting the research, finding the research study that calculated the therapeutic index for every one of our psychotropics. And so you could put a chart together. I don't know anybody who's done that. So let's look at lithium. The lethal dose is around at which 50% of organisms on lithium would die, is at a blood level of 7. And calculating the effective dose at which 50% of the organisms would show a response at 1, then the therapeutic index for lithium is 7. So it's above the 5. I like the certain safety factor better. Just, it fits my worry about harming patients. And the certain safety factor is the lethal dose at which the first organism dies divided by the dose at which 99% of the organisms are going to show the dynamic response to the medication. So let's have a look at the certain safety factor for lithium. And there is in the literature cases where people at a dosage of blood level 2 on lithium die. So we'll say the lethal dose for 1 is a 2 and the effective dose is 1.2, because that's the high end of the therapeutic range. So that should be theoretically the range where 99% of people show a dynamic effect. So the certain safety factor calculated for lithium is a 1.66. It is simply the case that lithium is probably our most dangerous medication in terms of lethality. There are medications in other systems managed by other practitioners that have a much narrower therapeutic index, where the lethal dose is just twice the therapeutic dose. And the examples that I would give you would be in cardiac meds, medications that are managing dysrhythmias in cardiology. They have medications that have very narrow therapeutic indexes. And so for that reason, you want, if you're thinking about classes of drugs, as you're looking at what your medication interacts with, and if it is a cardiac med, you would want to be much more wary about giving something that induces or inhibits the blood level of a cardiac med than you would be, for instance, of an analgesic. Because if you inhibit or induce an analgesic, you're much less likely to kill a person. Dangerous drug reactions. Well, we know about these, but we're going to review them. The neuroleptic malignant syndrome, agranulocytosis, which is a drop in the white blood count to less than 3,000 or below 50% of baseline. Anticholinergic side effects, serotonin syndrome, a hypertensive crisis, extrapyramidal side effects, and then the allergic reactions, with the most prominent one we think about being Stevens-Johnson syndrome, which is a systemic form of erythema multiforme, which results in skin loss, sloughing one's skin like you have been burned. And in the worst case, the person dies in a burn unit because they essentially slough off their skin. QT prolongation, which can cause or can induce torsades, which can induce sudden cardiac death, cardiac arrest, which is the heart stops beating suddenly, effectively. Urinary retention, which cascades sometimes from a urinary retention to a urinary tract infection to a renal infection that can sometimes even then go septic. And so you can, by giving an anticholinergic, which causes urinary retention, set somebody up for acute renal failure by inducing an infection that ascends to the kidneys. And with a substantial amount of kidney infection, you can have acute renal failure and sometimes permanent renal failure. And then if, depending on how leaky the kidneys are, sometimes could get a septic infection that infects the whole body. It is distributed through the bloodstream and into the interstitial space. Hepatotoxicity, killing the liver. The metabolic syndrome and rhabdomyolysis. And you know what rhabdomyolysis is? Rhabdo is, you're lysing your muscle, striated muscle. And that would be cool, except it's also your heart that is getting, when you induce rhabdomyolysis, you're also lysing cardiac fibers and not just bicep fibers. You tend to develop the pain. And how do you know somebody's got rhabdo? They got muscle aches. So you want to back off. You want to have rhabdo treated pretty quick. Hydrate the person. Get them to an ER.
And so a statin can do that, I heard, but then they recommend maybe taking CoQ10 or something else with it. So does that really stop the rhabdo? No.
If you don't want to induce rhabdo, and a primary care physician can help you calculate how much can you tolerate. They will tolerate, they back off of statins when you get rhabdo and get muscle aches and pains. Not so much because of this muscle, but because it can cause, it can affect the heart, it can affect the cardiac.
And the clue is the pain then in the muscle.
That's right. You'll know because the person all of a sudden pops up with muscle aches. And if they get muscle aches and they don't have a fever, and you need to have a PCP evaluate that if somebody develops muscle aches after they started taking your medication, to see whether there's another explanation for these muscle aches, like in the viral infection or something.
Is there like a degree of, because I'm old, I get muscle aches all the time.
Yes,
I wake up in the morning and
that's what that's. So, it's our lifestyle. I understand.
Is it a more pronounced kind of?
Yeah, it's one that you wouldn't explain. It's cramping muscle aches that you can't explain by this is a chronic condition of being older and having aches and pains and stiffness. All of a sudden, you develop just a cramping, aching pain in a muscle, and it usually it's whichever muscle is most vulnerable at that time. It starts out usually asymmetric, but it can escalate to the point where it's all your striated muscle. So yeah, you'll get a warning that it's starting, and you can back off of whatever the offending agent is then. But we do occasionally have people hospitalized with rhabdo. Hospital, I've seen several. And not from psychotropics, but other medications can cause rhabdo too. And drugs of abuse can cause rhabdo. So we'll have people coming in who have just, overdosed on, or taken, they were out partying and they induced rhabdo by taking all kinds of drugs of abuse. Then the acute dystonias, remember those are those muscle spasms early sudden onset of muscle spasms. And that can cause laryngeal paralysis and death pretty quickly. So it's not just benign, it's not just that you could get a muscle spasm that, yeah, we can back off of this, but they can be really serious if somebody's getting an acute dystonia. So you want to treat that with an anticholinergic pretty quickly. Then neuroleptic malignant syndrome, fever, rigidity, autonomic instability, clouding of consciousness. You withhold neuroleptics, hydrate the patient. You can give the person dantrolene, and that will treat it. But essentially, psychiatrists just turn the person over to an internist or a family physician to manage it when this happens. You need somebody to manage that. If it looks like they're getting neuroleptic malignant syndrome, that's go to the emergency room. If you're in a remote area, the fever can kill the patient, and so you put ice packs in their armpits and get them to an ER to try to keep the fever, the temperature down, and get them there to be treated by and stabilized by a physician in emergency. And then serotonin syndrome, it's exacerbated by the use of two serotonergic agents, combinations of serotonergic agents and over-the-counters that are serotonergic, like SAMe or St. John. And what are the symptoms? Altered mental status, fever, agitation, tremor, myoclonus, hyperreflexia, ataxia, incoordination, diaphoresis, shivering, diarrhea. The person will look really sick. And so, obviously, if you start a medication, or your patient's on a medication, and they look sick, then you need to have them evaluated. And if it turns out it's serotonin syndrome, then you got to back off of some serotonergic agent. So the mnemonic for serotonin syndrome is shivers. It's shivering, hyperreflexia, increased temperature, vital sign instability, encephalopathy, restlessness, and sweating. This chart's a little hard to see, but it has serotonin syndrome and neuroleptic syndrome on the left side, and the clinical presentation looks fairly similar with both. Looks pretty similar. The one difference is with the neuroleptic malignant syndrome, it looks a bit more like extrapyramidal side effects. And then with malignant hypothermia, again, nothing we prescribe will cause malignant hyperthermia, but again, medications can cause that. So what do you do with serotonin syndrome? Cut down on the serotonergic agents. You can use cyproheptadine to block the serotonin receptors, but again, you're going to have a physician who's managing, stabilizing people's vital signs. You want somebody who's familiar with doing that, an ER doc or an internist to manage that.
So serotonin syndrome, is it like a rapid and acute onset?
Yes.
As opposed to the neuroleptic, which is a course of 1 to 3 days?
Well, both can, yeah, that's rapid, I think. It's very hard to tell the difference. The main difference is you're going to see more muscle spasm and more extrapyramidal type side effects with the neuroleptic malignancy. That's the main differentiating characteristic between the two. Now, Stevens-Johnson is only one of several drug allergies. There's also toxic epidermal necrolysis, and this is basically death of your skin. Dress or drug rash with eosinophilia and systemic symptoms, and then other kinds of allergies. Now, I'm not recommending you look at these pictures, but you may want to look at the pictures at that length. If you have not seen what Stephen Johnson's looks like, then you can look at those pictures, yeah.
Some people give out pictures as part of their informed consent of these things. Do you recommend that?
It hadn't occurred to me to do that. We are pretty careful in describing to people that if they develop an allergy, and what to look for, which is a rash around their mouth, their gums, bilateral rash that starts after they start a medication, to call in and come in and have it evaluated. But I think the pictures, well, that might help. But there's so many medications that can cause drug rashes, and Stevens-Johnson. Ours are not the only ones. Aspirin can cause Stevens-Johnson syndrome. So essentially, as part of the informed consent, we mentioned that some people develop a rash as a result of this medication. And so we described what to watch for, but I've never given out the picture. So I'm sure some people might do that. But then if I was going to be that thorough, I would also be giving detailed descriptions of all of the other low frequency, high risk. If this happens, if this happens, if this happens, if this happens. And the general tendency, the trend, the standard of care is to mention the most common, the most likely side effects in doing informed consent, and any very untoward side effects that are also likely. So you warn about the more frequent ones that can occur. So I think I handed out the Texas algorithms side effects. There's a sheet that I handed out in one of my classes here. On one side, these are common side effects. You can mention at your next session. These are more serious side effects, and so you should call in or go to the emergency room if any of these happen. And that's a more comprehensive list of outpatients. Okay. QT or QRS prolongation and torsades we've talked about. Genetic polymorphisms, examples, the ethnic differences in the isoenzyme systems. We talked about familial patterns in drug responses. And then here's pharmacoepidemiology. And I think in the supplemental materials I gave you a drug list from the CDC. We know about tolerance, dependence, and withdrawal. Tolerance, metabolic tolerance, we talked about, is induction in the system. Physiological or pharmacodynamic tolerance is caused by cellular or up and down regulation, which can lead to physical dependence and an abstinence syndrome. And the behavioral is where a person learns to decrease the effects and to compensate for the effects. Rationale for medication selection, taking into account the characteristics of the patient, the diagnosis, target symptoms, patient's family history and personal history, and the adjustment prior to the onset of the illness, their environmental factors, comorbid medical conditions, and what existing medications are the patient taking, the options of the medication, potential for interactions with the current regimen, proposed regimen evaluated in the light of differences among medications within classes, costs, the patient's attitude toward meds, likelihood of adherence, attitudes of the patient's support system, and the patient's prior experience with medications. You consider all of that stuff when you select a medication. Okay? Remember, we are treating not diagnoses, but symptoms. Symptoms related to neurotransmitter systems, and that's what we're modulating, is those systems that either enhance or inhibit symptoms or psychological experiences. remember that drugs can be referred to by structural or chemical names. That's not the generic name. And then generic or non-proprietary names, those are made up. And then trade or proprietary names, and those are made up at a second level. And there is a committee composed of FDA members, members from the American Medical Association, and other medical societies that participates in the naming of every new drug. And it is hotly competitive because the company that's produced the drug wants to name the drug in a way that it implies that this is the best drug God ever created for this purpose. And the FDA wants to hold the name as close to the chemical name and the class as possible. So they try to have generic names indicative of a class action. And the American Medical Association tries to resist also, along with the FDA, the pull in the direction of naming medications things like Vyvanse, Vivacious. Notice that the companies producing these trade names, they want that name to imply excellence. Yeah. And so those, I've actually been at a cocktail party with people who sit on those committees who talked about what a combat zone it is to just select the name. But remember, underlying these generic names that you're learning, as well as the trade names, are the actual chemical names that a chemist would be able to construct, could draw the molecule for you. And that's the real name of that medication. Okay, psychotropics, here are the major categories. Pharmacotherapeutics is the action of the medication. It can be anticipated by the receptor types that the drug plugs into. They have functional specificity. Remember, some drugs plug into more than one site. I've said this several times, the drugs have only effects. You will be able to anticipate the drug's effects by knowing what receptors it plugs into and where those receptors are located. So Stephen Stahl says, you never need to know the name of the drug. What you need to know is what receptors it plugs into, and that's what these references tell you. That the name doesn't matter. You look at how the affinity of this drug for those receptors, and you'll know exactly what it does. And so when you're comparing second-generation antipsychotics, look at which receptors the drug plugs into and which ones are similar in which receptors they plug into. And there's a limited set of receptors. Remember, there are serotonin receptors, there are dopamine receptors, there are norepinephrine receptors, there are acetylcholine receptors, there are alpha receptors, there are beta receptors. That's about it, right? That's about it. Receptors for those neurotransmitters you've been talking about. So when you, and also those others that modulate cardiac function, pulmonary function, renal function, those receptors. So if you look at all the receptors a medication plugs into, where they're located, you'll know exactly what that drug does, what it's going to look like in terms of therapeutic effect, and what is classed as a side effect. So that's why, if you look at the second-generation antipsychotics, you'll see how similar olanzapine is to clozapine, and how similar Seroquel is to olanzapine, and how similar Geodon is to Abilify, and how risperidone sort of bridges between Abilify and Geodon and Seroquel.
Do the dones go together that way and the, you know?
It'd be nice if they did.
Okay.
And they sort of do. Yeah. But it's more, look at the receptor sites. So that's what, from now on, what you're thinking about is what receptors does this medication have an affinity for? And the next medication down the pike, it may have a novel action in that it plugs into and enhances neurotransmission using or exploiting a different kind of receptor, a different receptor site. So a new medication that's an SSRI may exploit a different subcategory of serotonin receptor. Okay? Side effects can be caused by the drug plugging into a type of receptor in an undesired area. The drug doesn't discriminate. Drugs distribute through the body and plug into receptors of that type no matter where they are. Drugs plugging into receptors in desired areas, that's the therapeutic effect. And drugs plugging into undesired areas, that's what we call side effect. A drug has several receptor types into which it plugs. Part of the drug is therapeutically useful, plugs into the receptors producing the therapeutic and potentially also the side effects as in above. So sometimes the drug isn't that discriminative. Sometimes it is. So in managing medications, it's important to consider all of the effects, because you can use what somebody else considers an unwanted side effect therapeutically for a patient. So for instance, an antidepressant's main job is elevating mood, but if it has a sedation as a side effect, then that may help a patient who also has insomnia sleep, and therefore the medication may work better because not only does it elevate mood, but it also induces sleep. A single drug that plugs into more than one receptor can produce more than one therapeutic effect. Venlafaxine hits both 5-HT and norepinephrine. You can class drugs in a number of ways. Most frequent is functional based on the main method of action. They can also be classed on the structure. Okay, now, I wish you could see this, because this is my nifty chart here. I produced this chart, and you can blow it up at home. Can you find this on your computer? Do you have this booted up so you can see this a little better? Okay. The National Register of Health Service Providers is putting out a series of videos training people in integrated primary care. So I did this chart for non-prescribing psychologists to help them try to understand medication selection. And so I, across the top, listed, can we blow this thing? I'm going to have to blow this up completely. I can't see that. There we go. There we go. Okay. Across the top, we have 5-HT, norepinephrine, dopamine, an arrow through the acetylcholine, so that's blockade of acetylcholine, blockade of histamine, and GABAergic increase its agonism of GABA receptors. So it's plugging into GABA receptors. And then if you look down the side, you see depression with low energy. And in that case, if somebody has an anergic depression, then you would want to pick an antidepressant that improves mood, 5-HT, but also increases energy. And so that would be hitting the norepinephrine receptors and the dopamine receptors. So as you see, I've listed on the right bupropion and venlafaxine. Bupropion is an NDRI, venlafaxine is an SNRI, and selegiline is an MAOI. So selegiline increases all three. And selegiline is an MAOI that is available in patch form, which makes it much less problematic with regard to interactions with dietary interactions. And then if you have a depression with anxiety, see, I've put the X's under 5-HT and also under blockade of histamine. So you see fluoxetine as an SSRI, that's just plugging into 5-HT. And trazodone, an SARI, plugging into 5-HT and histamine receptors. And then for the condition anxiety, we've got the X's there for 5-HT, as well as blockade of histamine and increasing GABA. So we see citalopram as an SSRI, doing 5-HT only, buspirone, which is a selective SSRI, and hydroxyzine and diazepam, hydroxyzine being histamine blockade, and diazepam, which is GABA.
Are the other ones, do they hit GABA? SSRIs?
No.
No.
So what I'm trying to show is options for medication selection to treat particular symptoms. And to help somebody who doesn't understand these medications understand what might be behind the choice of a particular medication. Now, there would be other factors that would affect which of those channels you exploit with regard to anxiety. For instance, the factor of dependence, which might steer you away from GABA, and the long-term use without sedation, which might steer you away from an antihistamine and toward an SSRI. I haven't included all of those factors there, but what I'm including is just the neurotransmitter systems and how knowing something about how they work might affect your choice. Now, you could do this same kind of chart for antipsychotic medications. I haven't done that yet because that was advanced of what the National Register was wanting in this series.
What's the difference between 1X and 2?
It's how strongly one might recommend using that, making that choice. And then if you look at insomnia with depression, well, you can use 5-HT and something that is antihistaminic and anticholinergic, like trazodone and mirtazapine. With depression and pain and insomnia, something that hits both 5-HT and norepinephrine, and it may be anticholinergic and antihistaminic, like amitriptyline. So it hits all those channels. And then insomnia without depression, baby GABAs, the zolpidem, the Z drugs. And then if it's physical pain, hitting both 5-HT and norepinephrine. We know that the SNRIs, that both just serotonergic effect can reduce pain sensitivity, as can descending signals in the norepinephrine system block pain. So is this making sense? Okay, down at the bottom then I'm explaining to the naive what each of those symbols means. So this helps this is sort of how I think about these, and how I think it's fairly common to think about these medications in the field in terms of considerations for medication selection. Okay? All right. Now I want to move back to the mini version so we can go on. Let's see if I can get this one.
Looks like Casey has a question.
Casey?
John's SARI.
Yes. Okay, so he's found it. Sorry. All right. The main point, we target symptoms, not diagnoses. Relate the symptoms to the neural tracts and neural circuitry. And mostly what we're doing is increasing neurotransmission or reducing neurotransmission, or modulating it or reducing. A single medication may affect more than one brain circuit or region. The effects in one or more circuits may or may not be desirable. Now, the FDA approval process. All drugs requiring a prescription are FDA approved for use. It also approves for specific indications which reflect the proven efficacy of the drug for a specific condition. Prescribing for a use which has not been proven to the FDA is called on-label. No, that's not right. Oh yeah. Prescribing for the use that is proven is on-label. Prescribing for other conditions is called off-label. It's entirely legal from the FDA's point of view to use medications off-label. If we didn't use medications off-label, there would be no way you could medicate children.
Right.
And elderly people. And there'd be no way you could use most drugs for conditions that we know that class or that method of action induced by that drug works for a particular condition. So off-label prescribing is very common. In New Mexico, we can prescribe off-label as prescribing psychologists. But in order for us to utilize a drug, it has to be on-label for some condition in the DSM, the current version of the DSM. That's what the law says. Then we can use it off-label for any other psych condition. What age range is it safest to prescribe for?
24 to 48. Yes.
That's wrong.
We don't even need him here, we can say all the things he says.
It's not 24 to 48.
It's not 24 to 48. That's not the safest.
12 to 24?
12 to 24. Why?
Isn't it most Brazilian?
Yeah, their bodies are fresh. Their livers haven't been wrecked yet. Their kidneys are working. Adolescents chew through medications. You have to give them often big doses because they metabolize the stuff like it's going out of style. To get a therapeutic level of the stuff, they got to take oftentimes big whopping doses of stuff. And that makes you real nervous because you're thinking, well, this is a child and I want to protect this person. don't want to harm this young person. They're the least likely to be harmed. But once they hit adolescence, they got adult organs, except for the brain is not adult. The brain isn't done till when? 26 to 28. It's done sooner in women than it is in men. I don't want to bring up a sore subject, guys. But you know that women mature more quickly than men do, and the executive area of the brain matures more quickly in women than it does in men. And that's the last slide in that batch. So that is the straight pharmacology. This is what you've been waiting for. I mean, this is why we did this, right? This is why we take all this education. It's so we can do clinical psychopharmacology. It's so we can prescribe these drugs and help people. All of that, everything up to now is just preamble. And this is the main show.
On the last day.
And the trouble is, you know it best. You already know it well enough to pass the test without restudying this stuff. Because this is what you were interested in the first place, is all of these medications, what they're used for, what conditions. This whole last set of classes has been about clinical psychopharmacology. How many weekends have you spent on clinical psychopharmacology?
Since January.
Yeah, at least eight weekends, 9 weekends. So most of these classes have been devoted to, it's either pathophysiology or clinical psychopharmacology. You're much more familiar with clinical psychopharmacology. The application of pharmacology to the management of psychological behavioral disorders includes the indications, contraindications, dosing, adverse effects and toxicities of psychotropic and adjunctive medications, interactions with other medications, including other drugs used in medicine, for recreational purposes and available for over-the-counter, as well as the management of adverse reactions, overdoses, and toxicities. So it's knowledge of the various psychotropic and adjunctive medications, their indications, contraindications, and off-label uses. Now, all of those give you guidelines, but I've said this before, I'll tell you again. These are the granddaddy best references, the ones that you will use when you're actually functioning. Because these tell you dosing regimens, they give you these resources. Clinical pharmacists, when they discover that you have these and they haven't seen them before, because they know 2,400 and some drugs, and now they discover there's this kind of depth just for psychopharmacology. They keep borrowing these out of my office. These are now available online because they were updated frequently. You buy them, and then you register, and for about $100 a year, you can get all of the information. They're just available online and updated with new drug information. So I just offer that to you, that as in terms of permanent references that you will use, this is the deep background on these medications that you'll use while you're functioning. Because it will list every effect. So, for instance, here are the third generation antipsychotics, and it gives you drug interactions, And down the left side is with every class of medication. How does it interact with medications by system? And so it takes a little while to use, but it gives you the deepest information. I use this all the time in treating children and in evaluating stimulant medication, calculating how many kilograms the child weighs. This gives you the limitations. This tells you stuff about that is beyond what the FDA-approved information tells you about it's the practical management of these medications. So, oh yeah. So you look in the.
How does it compare with the stall book?
Oh, stall is very superficial compared to this. By that I mean, if you look at Hippocrates and you look up a medication and you say, indicate pediatric dosing for peds, and it says there are no recommendations. Because the studies have not been done there, it's not going to tell you how to treat a child with this. This reference will tell you what is the standard of care for managing this medication in a child. So this gives you evidence-based, deeper, solid information. When you're practically managing psychotropic medications, these are the resources. But there are also these other guidelines. And remember, the Texas algorithms gives you an idea about starting and switching antidepressants, antipsychotics. Guidelines.gov keeps updating. This is your government at work for you, giving you guidelines for treating various conditions. The American Psychiatric Association has guidelines for you treating various conditions. And the Brits and the Canadians, you can click on that reference there. They have very specific guidelines for treating psychiatric conditions with medications, dosing schedules. The truth is, you can check to see, is what I'm doing here consistent with what those guidelines say? But you don't just follow those guidelines like a cookbook. But when in doubt, it's better than guessing. I'm going to need to take another break here. So we'll take a break and then move on through this. So let's take about. The APA says that we need to have knowledge of dosing, the time course of therapeutic action and adverse effects, and patient factors that influence the dose, like weight, gender, ethnicity, and age and concurrent diseases. The usual patterns in the time course of therapeutic action, and the most common timing of adverse effects. Knowledge of therapeutic monitoring, augmentation strategies, and dose adjustment, both titration, cross tapers, and discontinuation. Define the following: titration and cross taper, discontinuation, factors that need to be considered, and knowledge of the routes of administration, oral, intramuscular, IV, inhalation. Which of those is fastest?
Inhalation?
They're probably close to equivalent, IV and inhalation, because inhalation is very rapid also, but IV is in your bloodstream. And so it's going to hit your brain within a minute. And inhalation, it takes diffusion across the capillary walls in the lungs, so it takes slightly longer, but it's still very rapid. It's part of the reason the administration of nicotine by inhalation is so addictive, is that it hits your brain real fast. Differential response to various groups. knowledge of specific drug toxicities, adverse reactions, including overdose, indications for referral for appropriate medical care, like acute allergic reactions, extrapyramidal symptoms, and a hypertensive crisis. Reviewing medications by class. There are a number of lists, and I think previously you've probably gotten the clinician toolbox, the one that is has a list of the medications by generic and trade names. And in the supplemental materials I've distributed, there are copies of those. And then there's also the one that is the John Preston's list. By the way, the clinician toolbox one, that one, I was giving a lecture in Chicago and talked about it being produced by Ed Zuckerman and I forget who it was now. We used to do it, and Pam Caden was there and she said, no, actually I'm doing this now. I did not realize she had taken over doing it if she was in the audience at that time. And that's a very useful list because it lists out by alphabetically by trade name and generic name all of the medications. Antidepressants increase psychomotor activity before the antidepressant effects. And that's why they increase suicide risk on initiation. Now, the reason there's a black box warning on the SSRIs is that the relative risk of suicidal ideation doubles. You get 100% increase in the relative risk of suicidal ideation, but the absolute risk increase is 1%. So the risk of suicidal ideation goes from 1 to 2%. So the absolute risk of suicidal ideation at the onset of treatment with an SSRI is relatively low, even though it's not zero, and there's a black box warning because of that. But I think you know that as a consequence of the black box warning, there was a marked reduction in the prescription of SSRIs and a concomitant increase in suicides because people who should have been treated with SSRIs weren't being treated with SSRIs. So it's something to warn the patient about is you may, some people, rarely, but some people have all of a sudden thoughts of suicide. If you do, stop taking the medication and call us, come in right away, go to the emergency room. It'll go away if you stop the medication. And so you let the person know that's a possibility, but it's not a reason to not prescribe the medication. And then the next issue with regard to the antidepressants is how lethal are they in overdose? What about a bottle of fluoxetine? How lethal? A full month's supply of fluoxetine. Is that a lethal dose of fluoxetine?
No.
No. And that, I don't tell patients that. Because if they're going to overdose, I want them to do it on their fluoxetine and not on Tylenol. Okay? Overdose of benzodiazepines, is that likely to be fatal? No. An overdose of barbiturates? Yes. An overdose of opiates? Yes. An overdose of alcohol? Yes. You can call poison control and ask them, my patient took X. How likely is that to be a lethal overdose? And they'll tell you. Poison control has a list of all of the agents and how likely they are to be, cause toxic results. Yeah.
I thought that the benzos could slow down breathing and stop breathing in high enough doses.
Yes.
But
Slow
still,
it way down, yeah.
but they're still not that deadly?
Yes, not like the opiates. The opiates will, that's basically how they kill you, is that they hit the respiratory center and you stop breathing.
So somebody took a month's worth of Xanax or lorazepam or something?
Just sedate the living daylights out of it.
Doesn't that also suppress respiratory?
The respiratory drive, but it doesn't stop respiration in the same way opiates do. It's more dangerous to take a month's supply of a benzo than it is an SSRI. A month's supply of a tricyclic will kill you. So that's pretty hazardous because that can cause cardiac arrest. Overdoses of tricyclics do cause cardiac arrest. Patients with resistant depression can receive augmentations. We'll talk some about the augmentations. The pharmacotherapeutic action of the antidepressants is primarily inhibition of the reuptake of 5-HT, norepinephrine, and dopamine, depending on the agent. Downregulation of 5-HT2 receptors and beta-adrenergic receptors. Antagonism of alpha-adrenergic autoreceptors and presynaptic heteroreceptors increases the synthesis and release of norepinephrine and serotonin. And antagonism of postsynaptic 5-HT2A and 2C receptors minimizes the serotonergic side effects. So when they get more selective, then it minimizes the side effects. Antagonism or blockade of acetylcholine receptors causes urinary retention. And CNS stimulation from imipramine, like propranolol, can cause an antidiuretic effect, and again, that's another mechanism for causing urinary retention. Why do the antidepressants work? I'll let me see, do I want to try to talk through that or not? I've explained that to you before, so I'm not going to explain the upregulation and downregulation and how that relates to how the SSRIs begin working. Antidepressant medications work best for individuals who have the vegetative signs of depression. So somebody who's got what we used to call a dysthymic disorder, or it's a personality disorder. It's a negative set toward life with many negative cognitions, but without the physiological signs of depression, they don't respond to antidepressants nearly as well. It's the people who have the classic vegetative signs of depression that are going to respond to an antidepressant. And the vegetative signs are energy, low energy, gross fatigue, anhedonia, which is an absence of a drive for pleasure or instinctual gratification, fluid food sex, cognitive slowing, sleep disturbance, especially that early morning waking with this anxious preoccupation and the inability to go back to sleep. Antidepressants work less well for people whose depression is secondary to a physical cause, like a medical illness, or substance use or dependence or abuse. Persons whose depression is what we used to call characterological, based on lifestyle, based on habitual ways of thinking, based on ideas commonly held in their social milieu. And they work less well with people who have bipolar disorders or schizophrenia who are depressed. So, yes?
What do you mean by based on ideas commonly held in their social milieu? What would be an example of that?
Well, there are certainly, let's say, cultural groups or even religions that have a very negative set toward the world. And, you know, the world is a bad place and a dangerous place. So it's, you know, social consensus kinds of ideas that lead a person to feel rather hopeless with regard to functioning within the world. And so it's that kind of consensually validated assumptions about the world and how to function in the world. That's, you're not going to be able to medicate somebody out of a millennialist type of religious belief.
Are there any particular religions that have been associated with higher rates of depression or not responding as well to the antidepressants?
You know, I don't know that anybody's studied the relationship between religious and affiliation and antidepressant use. So I don't know the answer to that. But there's a lot of research in the pastoral care and pastoral counseling literature with regard to various kinds of religious ideas and how that is associated with psychological variables. So you can look at the pastoral counseling literature. There's a lot of work done there. But remember, you're going to medicate somebody who's got bipolar disorder with a mood stabilizer, and they're going to tell you that they are depressed once they're stabilized. They're going to say they don't feel like themselves, they don't have the zest for life, they have a general, mildly negative affective tone, and so they're going to present as depressed and say they are, and you're going to want to pop them out of that, and you're going to try to give them an antidepressant. And it's very common to see people with bipolar disorder on antidepressants, but it doesn't pop them out of that mildly dysphoric state, because they really like that high energy, dopamine driven mania. And there's not, you don't feel thrill if you are properly medicated with a mood stabilizer and a bipolar disorder. So don't try to medicate them out of that, because all you're going to do is drive the antidepressants up to toxic levels and end up with side effects due to being on polypharmacy without getting a good therapeutic effect. What works in treating major depression? Time. Works better than anything else. A major depressive disorder, the normal course of a major depressive disorder is that it resolves idiosyncratically within 6 to 8 months in 2/3 of patients, if you do nothing at all. No therapy, no intervention, no medication, if the person manages to survive. So remember, you're racing against nature when you're trying to treat somebody with a major depressive disorder.
What period of time?
6 to 8 months. Now, that's not everybody with a major depressive disorder, but that's the time course for those kinds of vegetative sign major depressive disorders. The natural life history is 6 to 8 months. And then aerobic exercise works. Proper nutrition helps. Reduction in stressors helps. CBT helps. And oh, incidentally, psychotropic medication may help. Okay? Dr. Andazola, medical director of the Family Medicine Center and the Southern New Mexico Family Medicine Residency Program, says our job is to do, and he means all of the providers, physicians, psychologists, he's talking about physicians. He says to them, our job is to do as much of nothing as possible. Because anytime you do something to a patient, you take on the burden of the effects, some of which are not going to be desirable. And so caution with regard to intervening is a really good idea. So our tendency, once we have this tool, may be, okay, now we got this tool, we got to use it. Well, no, actually, one of your jobs is going to be, now that you have the tool, so you have the power to prescribe, is to exercise the power to not prescribe, is to take people off medications and to redirect them toward behavioral and non-biological interventions and health maintenance rather than using psychotropic agents. Okay, the SSRIs. Fluoxetine Prozac has a major metabolite, norfluoxetine, with a 7-day half-life. So a 7-day half-life means that that medication is going to be hanging around a real long time, because there'll still be a quarter of it in their system at 14 days, an eighth of it in their system at 21 days, 16th of it in the system at 28 days. That's why the elimination, the trailing off, the elimination half-life is way out there on fluoxetine. And that's why it's you can just have somebody stop fluoxetine. And it's also why they can forget to take a dose. They can take it every other day. They can take it every third day. And
Don't they have a 7-day pill or something now, too?
There may be, I don't know.
Yeah.
There may be a time release one or something. Then it would last, oh good heavens, long, long time. Sertraline it's nice in that it has less interference with the CYP450, the CYP450 system. Paroxetine has a large degree of CYP inhibition. Citalopram, it's the most selective of the SSRIs. It has the greatest affinity for blocking reuptake. Citalopram and daughter of citalopram, which is what? Escitalopram. Those are the most selective for actually causing the serotonergic effect is citalopram and escitalopram. Therefore, they're going to produce the side effects of SSRIs at the highest rates because they have the best fit. Then fluvoxamine, we talked about it. It's the first approved for OCD, and I explained why that was. Clomipramine, anafranil, even though it's related to the tricyclics, it's also relatively selective for 5-HT. And that's why, in fact, because of that serotonergic effect at higher doses, was the first medication approved for OCD, was because it was serotonergic, and more serotonergic than the other tricyclics. Now, remember that all of the SSRIs have nearly equivalent therapeutic efficacy. Nearly. They're useful in anxiety, depression, obsessive compulsive disorder, and panic disorder. Here are the half-lives. So notice it selects citalopram and escitalopram fairly long, fluvoxamine not so long, and look at desoriltrazidone is pretty short. Nifazidone is not available anymore. Venlafaxine is very short. So think the ones that are going to cause an abstinence syndrome are the short half-life ones.
What syndrome?
I'm sorry?
What syndrome did you say?
Abstinence syndrome. So somebody's going to notice, oh, I missed a dose. And this is why there is an extended release version of venlafaxine, is because people who take venlafaxine, if they miss a dose, they suffer. And
Because of the short half-life?
yeah,
But that doesn't happen with trazodone, right?
because trazodone is so, yes, it does. It's very antihistaminic, and yes, people do notice, but they want it to wear off. Because it's so sedating, so they tend to feel better when it wears off rather than worse. Yeah.
Yeah, but with effects, it's those shock, that's what I was talking about yesterday, the shock effects and whatever that they talk about. People, for some reason, I've turned it around, but that, you know, when they're coming off the short-acting effects, or like they talk about, like, it's almost like they're being electrocuted inside themselves. Like you're describing.
Well, yeah, people describe all kinds of subjective unpleasantness, and that's
I
one
thought
of
that one
them.
repeatedly, though.
Yeah, well, but that's not the only one you hear.
Sure,
People
right.
just, they'll say they just feel sick. Not everybody feels that. They're going to feel something.
Prozac has such a wide range, too. Like 48 to 72 hours. It's really huge.
Well, remember that people differ in how rapidly they metabolize these.
And why is it a range where so many of them, it's just kind of like, well, 35? You know, it's,
I don't know.
that one's so,
That I don't know. I'm just showing you the numbers that are out there, okay? Now, these are the tolerability. And I think this is something that's interesting to think about is how many people dropped out of the drug study. That's an index of how tolerable the drug is taking it. Is the higher the dropout rate, the more intolerable it was to take the medication. And 3 to 5% of people dropped out when they were taking placebos, saying they were having such unpleasant side effects they couldn't stand it. With the tricyclics, look, it's 25 to 30%. And the reason we don't have any difficulty getting people to take bupropion is because it's not unpleasant to take. Well, 9%, only 9% of people with bupropion, barely, not much above the placebo, found side effects unpleasant enough that they dropped out and didn't continue. And the dropout rate is not necessarily just due to how the person felt, but pretty much so. Look at trazodone, because it is so sedating, 25% of the people in the trial dropped out. Nifazodone, again, Serazone, we're not using it anymore. Remeron, it's high, 16%. Again, that's because of the sedation, how sedating.
Right, but isn't that related to the dose? Like that U-shaped dosing profile for mirtazapine? Like if you're dosing at that low level, shouldn't when you get into that right trough range?
This is not going to, it's not that fine grained. It's just, they were in the study, they took the medication, that's how many dropped out, even with the appropriate doses where you would expect it to be less noxious.
Okay.
Okay? And so look at the SSRIs are around 15% of people find it intolerable enough that they dropped out of the drug study. Okay, here are the pregnancy categories. The 1D is Paxil. And the rest of the SSRIs, SNRIs, SARIs are C. Is C, does that mean it's safe to take the drug when you're pregnant? No. It actually means there may be some evidence in animal studies that there is some teratogenic effect, but there's no definitive data in human studies. The preferable thing is to not be on any agent if you're pregnant. However, the risk to the fetus of a mother who's experiencing a heightened stress level due to being depressed with the increase in catecholamines, that causes low birth weight babies. So if you don't treat a mother who is depressed, that's going to affect fetal development. And if you do treat her, that's going to affect fetal development potentially. In both cases, it's potentially. And so there has to be an informed consent decision made in conjunction with mom's OB or whoever's managing the pregnancy with the mom to decide the risk-benefit analysis and whether the various risks and benefits outweigh each other. So I have prescribed SSRIs in pregnancy with consultation. I've also encouraged pregnant women to discontinue SSRIs to see how they do prior to becoming pregnant, prior to going off oral contraception. Because 50% of people who have been treated effectively on an SSRI can discontinue it and not have a recurrence of the depression. Okay. On what basis do you select an antidepressant? Well, efficacy. What is it effective for? Which symptoms? Then the side effect profile. The time course or half-life. The dosing schedule. Potential for adverse effects. And the potential for interactions. Now this is the efficacy. This is a study done in, I forget what the year is now, 2010. 12 new generation antidepressants assessed. This is a very often cited study because it was trying to do head-to-head comparisons of efficacy of these medications. And basically it found sertraline to be most effective and reboxetine to be least, and reboxetine's not available in the United States. Affinities to receptors. So notice that the antidepressants have an affinity not only for the serotonin receptor, but they also have affinity for histamine receptors, muscarinic cholinergic, remember that's the stand-in for acetylcholine, it's the second column. Alpha adrenergic receptors and dopamine D2 receptors. So this is sort of subtle differences between the medications.
Are those numbers, like, what's considered high affinity?
700. Look at mirtazapine for the histamine reflectors. Okay.
That's why they get so tired.
Is that like where it maxed out or something?
I'm sorry?
Is that like where it maxed out or something? Like, all the other ones are like 0.16 or something like that?
And is that almost negligible, or is that?
No, that's
pretty high.
that any of these, it's going to have some action if there's an affinity for it. It's going to have some action in that system. So any that have an affinity for the histamine are going to be slightly sedating. So that's citalopram, fluoxetine, and that's why we give people mirtazapine. And if you put doxepin on there, it would be big too. The tricyclics would be big. But I'm trying to list the SRIs, SNRIs, and NDRIs here. And included mirtazapine because, it's got that big antihistaminic effect. So notice the difference between the SSRIs is, do they hit histamine receptor, and do they hit the acetylcholine receptor, block it, the muscarinic cholinergic. And notice that paroxetine is anticholinergic. Okay, and this is effects on sleep. All of the antidepressants affect the sleep architecture. And so the arrow direction is Whether it increases it, decreases it, and the number of the arrows is how strongly. Notice that bupropion may increase the length of time it takes to get to sleep, but doesn't really have any effect on other aspects of sleep architecture. But the SSRIs really do.
What is the NE?
No effect. Half-lives. I did that one already, didn't I? Pregnancy
Are
category.
you going backwards?
I guess I really wanted you to get those, so I put them in there twice. Man, it must have been late at night. Okay, risk of overdose. Notice that doxepin, which is a tricyclic that we do give because it's so antihistaminic, has a relative toxicity index here of 2.7. Notice the SSRIs are less than 1. And then you get to the tricyclics, and they are 3 to 4 times as toxic. And with doxepin being 90 times as toxic as Prozac and Paxil.
Dr. Romaine has asked the question, are there any high-yield research studies for the PEP on these topics, I guess, the STAR-D?
You might see STAR-D and KD results, a question about them. I don't think they'll specifically mention the studies, but it is possible that the revision would include a question from STAR-D and KD. Potential for selected medications causing QT prolongation based on a survey. This is expert opinion. For these antidepressants, more than 40% of the respondents stated they would always get an EKG. Starting amitriptyline, dizipramine, imipramine, sertraline, and venlafaxine. Unlikely to, if they're starting fluoxetine and paroxetine. Very unlikely that they wouldn't check it for doxepin. Now that is a bit of a surprise. It's heavily antihistaminic. It is a tricyclic. It's anticholinergic. I don't know quite why that is, except that's what that study in 2003 said. But remember, that's expert opinion, and that's why never believe expert opinion. Expert opinion is just anecdotal mythology wrapped up in chalk. Okay? MAO switching, starting and switching, as a rule of thumb, for switching to or from MAOIs, you've got to have a 2-week washout period with SSRIs. And then if it's fluoxetine, 5 weeks. And you really got to get that out of their system. Serotonin syndrome, you can get it as an interaction between SSRIs and TCAs. Also, some of the opioids, some of the stimulants, some of the psychedelics, some of the herbs, and other medications, including risperidone. So it can happen, you got to watch for it, with the MAOIs, are dangerous in combination with all of those. Serotonin syndrome, we've already reviewed what it is. Hypertensive crisis. It shouldn't be saying MAOI, major adverse reactions, up there. Because a hypertensive crisis is caused by an interaction with concurrent administration of vasopressor amines, stimulants, over-the-counter cough and cold preparations. Which ones? What over-the-counter cough and cold preparation is likely to make you more prone to a hypertensive crisis? what over-the-counter cold preparation can you use as a substitute for cocaine? Or meth? What over-the-counter cold preparation do you construct meth out of as a basic building product? Pseudoephedrine, yeah, or pseudoephedrine. The symptoms are an abrupt elevation in blood pressure, severe headache. Why do you get a severe headache with a hypertensive crisis? You're stretching those arteries. The blood pressure is actually causing those stretch receptors in the brain to go off. With MAOIs, what do you need to avoid? All cheese except for fresh cottage cheese or cream cheese. Meats, fish, caviar, cured unrefrigerated fish, overripe avocados, fava beans, sauerkraut, yeast extracts, beverages like Chianti wine or beers containing yeast. And those foods should be used only in moderation. The dietary restrictions now in the more recent research, it's not assumed to be as much of a problem as it used to be, but these are why we tend not to use the MAOIs, even though they are, as a class, the most effective antidepressants, because they increase serotonin, norepinephrine, and dopamine all at the same time.
And what happens if they eat the food with the MAOI?
Nick can show you. Starting and switching. Start low and go slow. Baseline EKG in patients over 40 with any TCA. Starting and switching SSRIs and SNRIs. Switching between SSRIs is tolerated as long as the dose is equivalent. So you can switch somebody from 20 milligram of fluoxetine to 20 milligram of fluoxetine, or vice versa, just blunt switch. When adding a TCA, start low because of the SSRI's 2D6 inhibition. Switching to SNRIs is dose dependent. Low dose SSRI dose equivalent switch is well tolerated. High dose SSRI cross tapering is recommended. What is cross tapering?
You're starting one while stopping another.
But the tapering refers to reducing the dose of the one they're on, starting at one dose and gradually increasing and decreasing.
Was that in those books where it showed that? Or was that Stahl? I mean,
Probably
there was
Stahl.
graphs.
Yeah, Stahl, but there are also graphs in these things.
Okay.
Approximate dose equivalents of antidepressants. Atypical antidepressants, bupropion, has no serotonergic properties. Cross-tapering off when switching from other antidepressants. When switching to, start at a lower dose because of 2D6 inhibitors may increase blood levels, raising the risk for seizure. With mirtazapine, cross-tapering is recommended when switching between mirtazapine and an SSRI, TCA, or SNRI. MAOIs, the washout period. The drug will wear off slowly, but if time allows, tapering off is encouraged. In case of abrupt cessation, monitor for delirium, agitation, myoclonic jerks, and insomnia. Abrupt cessation of TCAs or rapid decrease can result in cholinergic rebound. So what is cholinergic rebound? You've been blocking acetylcholine, and now you're taking off the blockade, and so you get this overabundance of acetylcholine, so you're getting parasympathetic rebound. So the GI system goes haywire, the person sweats, they get anxious, agitated, have a headache because they're getting vasodilated, and so you make them feel real sick. taper the dose at a rate of 25 to 50 milligrams a day every 2 to 3 days. With discontinuation of SNRIs and SSRIs, abrupt cessation can result in discontinuation syndrome. Those are the most common symptoms. A 7 to 10 day taper is recommended, lowering the dose by 30 to 50% every 3 to 5 days. Fluoxetine has a long half-life. Paroxetine is the shortest. That chart I showed you has it listed differently, but paroxetine now, I think, has the shortest half-life. Somebody look up in Hippocrates what it says the half-life is for paroxetine. Pull out that handy-dandy cell phone thingy you have, smartphone, and look at paroxetine and tell me what it says the half-life is.
Is it 35?
21 hours.
Yeah, but that's wrong.
21.
21 days.
21 hours.
21 hours. It's short. That chart was wrong. I was referring to a reference, but paroxetine has a pretty short half-life, and that's why you get a discontinuation syndrome with paroxetine, just like you do with venlafaxine. There have been anecdotal reports of discontinuation syndromes with mirtazapine. Remember, nifazodone is not used anymore in the U.S. Discontinuation symptoms from bupropion are uncommon. That's why in part, why the bupropion is so well tolerated is, people don't feel bad when they take it. They don't feel bad when they miss a dose. When do you abruptly discontinue antidepressants? When the side effects impact a medical condition, when the person is really being made ill by side effects of the medication. When there's acute substance intoxication and withdrawal. When the person gets hyponatremia, and what is the mechanism for causing hyponatremia when you take an SSRI? How does an SSRI cause hyponatremia? You know this. You do know this. We've talked about it. What's the mechanism?
I think Gabe knows that.
It's 5 letters.
SIADH.
That's it.
How did you know it?
Syndrome of inappropriate anti-diuretic hormone.
Because you said it yesterday.
So if you have too much anti-diuretic hormone, you don't diurese. So your blood volume goes up, and so it dilutes everything that's in your blood. And so your sodium gets diluted, so you end up hyponatremic. And also hypokalemic, for that matter. And hypo everything else that's in your blood. Okay? This is a chart of the effect on sleep architecture. It's too difficult to read. This is a reasonable algorithm for selecting medications for depression based on STAR-D. What they did was, so this is what they did the STAR-D thing. Start with citalopram. Why? Because it has the best goodness of fit for the serotonin receptor. Switch to sertraline if it doesn't work, or bupropion, venlafaxine. Augment with Buspar. Switch to mirtazapine or nortriptyline. Augment with lithium or thyroid extract. And then switch, if that doesn't work, switch to phenylcyclamine or mirtazapine or venlafaxine. That's 2006, published in the New England Journal of Medicine. So that's what, based on that, according to this ASCP curriculum, that's the curriculum for psychiatric residencies, This is the rational kind of algorithm. Now, would you really just do that ritualistically? Well, remember, all they ever got in the way of remission rates was 67% of those patients, even with all this fancy dancy stuff. Okay?
Yeah, it seems very not individualized.
No, it's not. No, they had that, but they wanted to systematically test this. And so they lockstep went through that. So it's a valuable study. I'm sorry?
Prozac wasn't even on there.
No. Physicians have a responsibility to know what the medication costs. Okay? This is from the ASCP curriculum. I borrowed some slides. We purchased those for educational purposes in the medicine residency, use them for educational purposes. They are arguing against the use of free starter samples. And why is that?
There was something about that last class, wasn't there?
It was on the test.
What's that?
It was on the test.
Sorry, it was on the test.
They're not going to be giving you starter samples for generic drugs, are they? They're going to be giving you starter samples for the newest drug that's just been produced, and it's going to be the most expensive thing in the market. So you're going to start a medication in a patient that when they have to start paying for it, costs $1 gazillion. And because SSRIs, it's a class effect, why would you use a more expensive SSRI when a less expensive one would work? The problem, the reason, by the way, I've got one of my colleagues who's finally forgiven me at the Family Medicine Center because I led the movement to stop having drug reps come in to the Family Medicine Center. And it took her a long time to forgive me because she ran the free clinic in town. And they utilized those free samples because that was, even in a free clinic, generics cost too much. But the problem is, you get people accustomed to and dependent on these high-dollar medications, and now somebody's got to pay for it. And so it influences your prescribing. They give you these samples. If you listen to their presentation, the research indicates, if you're a psychologist, you know this. The research indicates if you just listen to the drug rep talk about it, it's going to affect your decision making even if you're not consciously aware of it. So the only way to defend against this influence of a drug company trying to make profits is to not be exposed to their information, but only be exposed to the evidence-based information about the drugs. Initial treatment. Conclusion of a meta-analysis of 46 randomized controlled comparisons. Selection of the initial treatment might be based on cost unless there are individual patient preferences based on expected side effects. So this is what the psychiatrists are being taught is the best strategy is start with the cheapest SSRI in general. Because it's a class effect. SSRIs work because of the serotonergic effect. Mood stabilizers. Lithium, the anticonvulsants. All of those anticonvulsants are just what they say they are. They're anticonvulsants. And the mood stabilizers, except for lithium, started out as anticonvulsants. So they will suppress seizure.
Can we prescribe carbamazepine? Yeah.
Oh yeah. We can't prescribe topiramate, Topamax, in New Mexico. So when I have patients who need topiramate, I have one of the primary care docs prescribe it. And if you think your patient needs dopyramate, then you talk to their primary care doctor and ask them to prescribe it. As a prescribing psychologist, they give you more, they'll listen to you better if they know you're a prescribing psychologist. They will take recommendations from you. Long-term control of bipolar disorder, lithium. It is the standard, it is the industry standard. May stabilize catecholamine receptors, may alter calcium-mediated intracellular functions and increase GABA activity. Blocks PIP2 second messenger synthesis, reducing response to muscarinic, cholinergic, and alpha-adrenergic receptors. So basically, it stabilizes neurotransmission and desensitizes the neuron a little bit. So it slows neural firing down some. Crudely, to say it crudely, that's what it does.
Do some people use lithium just to control mania and then take them off of it after and put them on something else to maintain it?
You can use it acutely and switch to something else, but why do that?
Side effects?
And all of them have side effects.
Right.
And so it's trading one set of side effects for
Right,
another.
and some patients, I mean, I've heard of many patients who didn't tolerate it well. They didn't like how the lithium made them feel.
That's right. They complain, I'm a little depressed. And you say, okay, well then we'll switch to another one of these because you're a little depressed. No, you say, TS. That's the well-medicated bipolar patient is going to feel slightly dysphoric. The fact that you feel a little depressed is that you're now closer to normal than you used to be. And so it's part of the education process. Now, there could be toxicity reasons why, management reasons why. And if the person's not a reliable character, if I can't count on them to really take the medication on a schedule and to present for blood levels, and then I may say it's too risky to have them. The person has to be a relatively adherent character to be on lithium and to not be a risk to themselves.
Same with Depakote, right?
Same with Depakote, but not quite. With Depakote, it's a little more forgiveness in the dosing. With the others, with the anticonvulsants, there's a little more forgiveness in. With lithium, there's not so much forgiveness. And so,
You're saying that's more toxic?
well, if they overdose on lithium, that's bad news. Yeah. So,
That is serious, because I was thought Depakote was like the most toxic.
well, it's hepatotoxic,
Yeah.
but the lithium is renal toxic. It'll kill your kidneys. And it really is a long-term chronic effect of lithium. Half the time is hypothyroidism. So there are reasons to not have somebody on lithium. But it is sort of the industry standard for bipolar 1 disorder, severe bipolar disorder. Other mood stabilizers, valproic acid, promotes GABAergic activity, blocks voltage-dependent sodium channels, which decreases action potential. Again, all of these mood stabilizers are basically inhibiting neural firing and stabilizing. And that's why they work to stop seizure. Remember, seizure is usually induced by an imbalance between the glutaminergic layers in the brain, or glutamate neurons, and GABA layers, which inhibit the excitation caused by glutamate. And so what you're doing with the mood stabilizers is inhibitory, essentially. That's why a patient is going to feel mildly slowed down. And they're going to have a chronic kind of feeling of just not quite having the zest for life that they would prefer. And then notice that clonazepam is also, it's a secondary mood stabilizer. And the whole point of mood stabilizers is that they are doing in your brain what you need to do in your brain to avoid seizure. Crudely, trying to avoid seizure activity. All of the benzodiazepines will inhibit seizure. Because what they're doing is increasing GABA inhibition, that will, and in status epilepticus, you load somebody up with benzodiazepine. So the benzos, the reason clonazepam is listed there is because it's a relatively long-acting benzodiazepine that's also a little bit serotonergic. And so that's why it would be, and it was FDA approved. They bothered to have it FDA approved as a secondary mood stabilizer. Brain circuits that are affected, we've talked about this before. With regard to bipolar disorder, the British algorithms and the Canadian algorithms suggest combinations of medications using the second generation antipsychotics more aggressively for mood stabilizers. So when I had a patient come in who was acutely manic, I used the second generation antipsychotic in a pretty potent dose to cut into her mania. And actually, I had a patient, a young woman, teenager, who had got an injury and got a steroid injection, and that induced mania. And she was somebody who came from a family where there was probably a predisposition to bipolar disorder. And so she came in acutely manic. She had not slept for 9 days. And she was ricocheting off the walls. And so I gave her a loading dose of Seroquel because it's antihistaminic, it would help her sleep. It's a second generation antipsychotic, and it can be used as an anti-manic. And brought her back down to earth, and she actually was able to then go off of the Seroquel after the steroid worked out of her system. Okay, so this is sort of the chart of disorder and the medications that can be used. So for severe mania or mixed episodes, the first choice is lithium in combination with an antipsychotic, like a first or second generation antipsychotic. The second choice is Depakote in combination with a first or second generation antipsychotic. And the third alternative is carbamazepine or ziprasidone or quetiapine. Then for less...
Quetiapine being probably the safest of all of them, right?
Safest. Yeah, I suppose. Ziprasidone and quetiapine are probably equivalent.
Does the quetiapine also have QT prolongation?
No, not as much.
Right.
Yeah. So yeah, you're probably right. Yeah. But notice that that's you're sacrificing potency. You're sacrificing efficacy in exchange for safety.
Isn't that what
So remember,
just do?
remember the safest thing to do is nothing at all.
That's true.
And the most dangerous thing to do is the most effective thing. Because, no, really, that's the relationship. Because the more effect what you do has, the more, every time you have an effect, you also have untoward effects. So the more effective it is, the more untoward effects you have. So you're taking on the burden of the untoward effects when you try to be effective. Okay? So yes, I try to do as much of nothing as possible. So I would just sit in the room and watch her ricochet off the walls for 2 weeks until she was finally able to lie down and go to sleep. Now, you'll be okay, honey. Just relax. Yeah. You'll be okay. No, you have to do something. You have to do something. This is the difference between physicians and psychologists. We're trained to not do anything unless we're sure beyond a 0.05 probability level that it works and it is safe. And physicians are taught that somebody presents, you got to do something for them. And you can't just say, well, I'm sorry, I don't know what would work, so go away. Psychologists do that all the time. I don't treat that, and I don't know what would work, so go away, see somebody else. Yeah. Physicians don't have that luxury. They've either got to do what's evidence-based, or what is anecdotal, or what the experts say, or if they don't have any guidance at all, they use their own brain to try to come up with a plan of something to do.
But we have a lot more tools, psychotherapeutic tools, that we try to use instead.
Yeah, but they have them too. They have a relationship. They develop a relationship, and they mobilize them. They just don't think quite in a lab. Yeah, that's right. We've got more rituals. We've got more of these behavioral rituals that we said, we make ourselves feel good. Oh, we're going to do centering, and we're going to do this, and we're going to do that. And, we've got all these self-satisfying rituals that while the person's sitting over there looking at us going, how quickly can I get out of here? Kind of thing. I'm teasing us a little bit. But the point is, that it's a difference in mindset, yes.
And with the MD, well, we walk in as consumers and we expect something, and they know that, and we
Yeah.
know that, and so I think that's why it happens.
They're going to do something before you walk out. The watchful waiting, at least they've named what it is. At least they say, they give you something. And that act is kind of a ritual in itself. But most of the time, they're trying to do something that makes some kind of change happen. But see, that's why Dr. Andazola is saying, do as much of nothing as possible as a counteraction to that. But you're going to discover you are expected in a way you never have been before to do something. Okay? Now, with acute depression, they're suggesting lithium or lamotrigine. That's acute depression and a bipolar disorder. And what lithium has the best efficacy against suicide of any of the mood stabilizers, and also, actually, head-to-head, it is best in comparison to antidepressants. And then with maintenance, you can use lithium in maintenance doses, valproate, lamotrigine, carbamazepine, or even maintenance ECTs. Okay. What's FDA approved for acute mania? Aripiprazole, carbamazepine, chlorpromazine, divalproex, lithium, olanzapine, quetiapine, risperidone, and ziprasidone. For depression and bipolar disorder, quetiapine, Seroquel. Dual treatment. Remember it was the entry-level drug for primary care doctors to get them to start treating psychotic disorders, was that pill that is a combination of fluoxetine and olanzapine. And, it's a lot cheaper to just give those separately if you want to combine them. And then maintenance, FDA approval for bipolar, is aripiprazole, lithium, lamotrigine, and olanzapine. In pediatrics, pediatric bipolar disorder, this is the chart. MS means mood stabilizer. SGA is second generation antipsychotic. You can see the chart on the right. So the question is, with or without psychosis, and then which approach do you take? Continuation, discontinuation of mood stabilizers. Rules of thumb with regard to lithium. It's 12 o'clock. I'm going to take a quick break here and get some lunch and go to. And I don't feel good when she's above 1.2. And so how a patient feels, where they feel best with regard to lithium is to some degree patient dependent. And some benefit from doses or blood levels as low as 0.7. And essentially, you don't want to have the blood level any higher than is necessary in order for the person to function well. Lithium toxicity will look like sedation, drunkenness, and can include tremor and delirium. And my patient, if she gets at 1.3, develops tremor. So that's how we can just tell by observation whether I need to do another blood level and have her drop back 1 pill a day, to have her stay at that kind of optimum level for her functioning. Lamictal, it is not as prone to inducing Stevens-Johnson as we used to think. And I think, do you remember Elaine Levine's lecture about the genetic testing? It is possible to test for a gene that makes a person much more prone to Stevens-Johnson. And so you might well, that might be the only reason I would use the genetic testing at this point, would be to ensure that somebody I place on Lamictal is less likely to develop Stevens-Johnson. The problem with Lamictal is you really do have to titrate it up slowly, and if somebody discontinues it or runs out of their supply, you have to start them at a low dose and gradually increase it again. Antipsychotics. The first generation, the typicals, have one or many of these, some, not all, but many, are anticholinergic, anti-adrenergic, antihistaminic, cause extrapyramidal side effects because of the G2 blockade in the pyramidal system, and cause, therefore, Parkinsonian-like symptoms. They can cause the neuroleptic malignant syndrome and tardive dyskinesia. Remember, the PEP is the DSM-4-TR. The antipsychotics are used primarily for psychotic symptoms. Delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and the negative symptoms. So that's about diagnosing. And you don't need to know about the specifiers there. In the differential, you want to, if somebody appears psychotic, you want to make sure it's not due to a general medical condition, that it's not delirium, that it's not due to dementia, which would be a medical condition. It's not induced by substances, and then it's not due to a pervasive developmental disorder in a child or a young person. That it's not. Then with regard to the psychotic disorder, you want to make sure it's not schizophreniform, short duration, schizoaffective. In that case, you're likely to use a mood stabilizer. Not a personality disorder, and not simply a delusional disorder, and not a very brief psychotic disorder, because again, you take on quite a burden if you place a patient on an antipsychotic medication, a burden of risk. Now, the antipsychotics work for positive symptoms, but not for the negative symptoms. And positive symptoms with the exception of delusions. That you may well get rid of hallucinations with an antipsychotic medication, but a patient is likely to remain delusional for quite some time. And the reason for that is that delusions are a conclusion a person has come to that will explain all of the psychotic experiences they had. So they now have a set of schemas in their head, and just because those psychotic symptoms stop does not mean their schemas go away, their way of interpreting reality, their conclusions about what has happened to them. So delusions are resistant to treatment with antipsychotic medication. So if somebody is simply delusional, they're much less likely to respond to an antipsychotic than if they are having florid hallucinations. What you really cut into with an antipsychotic medication is florid hallucinatory material. This is the criteria for PCP intoxication. These are lab and neuroimaging results correlated. The physical examination and evaluation for medication initiation, this is according to Januzak. These are all the things that you ought to do. I think we saw that before. Here's a standard type treatment protocol for somebody with a psychotic disorder. You start the medication, you meet weekly to evaluate until an optimum response is achieved, and the positive symptoms are diminished, and the patient's able to resume their normal activity. And then you need to do behavioral interventions for social skill development, cognitive rehab, cognitive therapy, adaptive behavior modification, stress management. Psychotic symptoms simply get worse when somebody's stressed. And also do psychoeducation of the patient and the family. You're doing follow-up visits to monitor for signs of relapse, any metabolic side effects, extrapyramidal side effects, akathisia, any signs of neuroleptic malignant syndrome, and any signs of tardive dyskinesia. This is what you do following an acute hospitalization. Choosing antipsychotics. Here are the adverse effects by antipsychotic on the left. And these are the first generation. These are the second generation antipsychotics. And so you'll see Abilify, Acenapine, Clozaril, Iloperidone, Lorazepam, Olanzapine, Paliperidone, Quetiapine, Risperidone, and Ziprasidone. And notice that Clozapine is big in terms of weight gain, induction of diabetes, sedation, anticholinergic side effects, and orthostatic hypotension with some QT prolongation. The reason it is so unlikely to cause extrapyramidal side effects is because it's also anticholinergic. So remember that the antipsychotic medications that do deep tube blockade, they all do, that are also anticholinergic and antihistaminic are less likely to cause extrapyramidal side effects because they have built into them the agents that you have to give separately if they're on an antipsychotic that doesn't have the features that are anticholinergic and antihistaminic. So you either have to take a high potency antipsychotic and add an anticholinergic and antihistaminic if extrapyramidal side effects develop. Or you can just prescribe an antipsychotic that is anticholinergic and antihistaminic and therefore not have such a burden of extrapyramidal side effects. You look down at the bottom, you see ziprasidone, and you notice that it and iloperidone are more likely to cause QT prolongation. And aripiprazole, not much. Lorazepam, not much. But notice that all of them can do it a little bit. Now here's monitoring for the metabolic side effects. And this is doing the BMI, and notice that you should monitor BMI and blood pressure and fasting plasma glucose and the lipids for the antipsychotic medications. Here's costs. First generations, notice you can get Haldol for $4 a month. Here's the cost for the second generations. Big dollars. Big dollars. The generic clozapine is available. There's also a generic form of risperidone now, and it's still about $200 a month.
Question.
Yeah.
Do we still use Trolfon?
You know, I don't know whether it's still available. I've never seen it used.
I had a patient on it. That's what I was asking.
Yeah.
I was like, oh. And I asked the pharmacist, and she was like, I've never seen it used.
Well, it's because it used to be used quite a bit, but it's out of favor. I don't know that it's been withdrawn from the market.
I mean, I looked it up on, where the app is. And it said it was Trolfon, the brand name is not American, but the generic is available.
Is generic, yeah. Well, Hippocrates will tell you whether it's available or not when you look it up. Comparative efficacy. These are according to these various studies. Remember, the Katie study is the big gun. And so with regard to comparative efficacy, notice that olanzapine is the big winner when you look across all of these studies. Quetiapine, a bit. Okay, these are the first generation antipsychotics with dosing ranges. The limits of conventional, 1/3 of patients with schizophrenia fail to respond. Remember, that's that 2/3, 1/3 thing? So when in doubt, how many people respond? What percent of people respond to this medication? Yes, 2/3. I think it's burned into nature somehow. They have limited efficacy against the negative symptoms, the affective symptoms, and the cognitive deficits. And by affective, they mean depression. They are good mood stabilizers, but that's what affective means there. High proportion relapse. There are side effects and compliance issues, and safety issues. Second generations, fewer side effects. They're supposed to decrease the positive symptoms and improve the negative symptoms because they also do some 5-HT blockade and increase or stimulate some glutamate release in adrenergic receptors in the prefrontal and frontal areas. So rather than dulling the whole brain, which is what the first generation antipsychotics tend to do, they tend to dull the baser parts of the brain, and the higher cortical areas light them up a little bit to counteract the sedating, cognitive blunting effects of dopamine blockade. So they sort of reverse or counteract the reduction in dopamine transmission in the frontal cortices. Clozaril, extolling the virtues of Clozaril, it is the most effective antipsychotic. And olanzapine is baby Clozaril without quite so much of a concern about agranulocytosis. Notice,
Is that the one that's considered more likely to cause the agranulocytosis?
Yes.
1%?
sure. Risperidone, little extra information about each of these. Olanzapine, remember, it is next to Clozaril most likely to induce the metabolic syndrome and diabetes too. It's another way to kill your patients is to induce diabetes.
So with Native Americans who are very much, like
gotta be-
that should be your last choice.
Yeah, you gotta be real concerned. You gotta monitor for the metabolic syndrome. If somebody already has a problem with obesity, you need to be very wary. You've got to balance how dangerous it is to not cut into their symptoms versus how dangerous is it to take on the side effect burden and cut into their symptoms. And if an alternative will do, you choose the alternative. And so that would be a more potent and less sedating antipsychotic like ziprasidone, Geodon, or Abilify. Then aripiprazole is considered a third generation. It has greater than 10% of the cases drowsiness, insomnia, and akathisia. Now the most recent evidence suggests 20% akathisia. Less than 2% dystonic reactions, EKGs, abnormalities, sexual dysfunction, galactorrhea, and sensitivity. And greater than 2%, some extrapyramidal side effects, dystonias, but not much higher than 2%. Okay. Here are the receptors that and this is from Stephen Stoll, and these are the receptors that the antipsychotics hit. So notice how dirty Clozaril is. It's the bottom line. And notice, by dirty, I mean, we call a medication dirty when it hits all kinds of receptor sites. That's what the acronym DIRTY means. Dirty versus clean is how many receptor sites does it hit. So Clozaril hits the biggest number. You notice son of Clozaril is olanzapine, the next largest number. Notice ziprasidone hits, that's Geodon hits a number, but notice that it's not hitting the muscarinic and histaminic. So it's not sedating the person as much. And so that's why it's less likely to cause the metabolic syndrome. And notice Abilify then is relatively clean. Relatively clean. The cleanest is risperidone and Abilify, but the problem with risperidone is that it does alpha 1 and alpha 2 blockade, and it does induce weight gain more than Abilify.
The alpha 1 and 2 are, was that weight gain?
No, the alpha, that has to do with the alpha receptors are in the, let me think. Somebody tell me where the alpha receptors are. Somebody out there in radio land. Jonathan, I'm counting on you.
Casey's right.
My brain is not working well enough. Yes, heart, so they're affect the cardiac. So here are the second and third generation with the weight gain, the percents of people who gain weight, and you see clozaril is highest, risperidone is fairly high, olanzapine and clozaril are the highest. Hurdles about antipsychotics. We've talked about the QT prolongation, anticholinergic effects, antihistaminic effects, alpha antagonism, hypotension. So that the alpha antagonism, blocking alpha signals to the heart, causes the heart to beat with less contractility and slower, and therefore drops blood pressure. And dopamine antagonism causes extrapyramidal side effects, tardive dyskinesia, and neuroleptic malignant syndrome. Starting antipsychotics. Start slow and go slow to minimize the side effects. Check glucose, EKG, if you're concerned about the QTC, potassium, magnesium, and I say yes, do a CBC with differentials because you're wanting to watch for the blood dyscrasias. But you can start them faster when the clinical scenario demands, and that's, for instance, when somebody's acutely psychotic or they're acutely psychotic admitted to a psych unit, so their status can be monitored regularly, then oftentimes they're given higher doses, big doses of these medications. If the person's naive to antipsychotics, start lower, go slower. If they're a long timer, off just a few days, generally restart at full dose at less or equal to 2, rapidly titrate. If they're a long timer, off for a few days, start over with a titration. And acute agitation, rapid titration of haloperidol, for instance, and Zyprexa with Zyprexa, and then you get EKGs more frequently. With clozaril, slow titration, stopping antipsychotics, okay. Taper to avoid minor withdrawal syndromes and decompensation. You can get, if somebody's on a high potency and chronic use, NMS and tardive dyskinesia with rapid cessation. Where are they? This is where they are metabolized. We've talked about that some. Anti-anxiety agents. What do we use for anxiety? Antihistamines, benzodiazepines, buspirone, and the barbiturates. We're not prescribing the barbiturates now. I mean, we seldom see them used, except in what case? Where do you see somebody still on chronic barbiturate treatment? People with seizure disorders. That's about the only place you see it now, is neurologists who are treating people with seizure disorders sometimes have patients on barbiturates. But we don't see them very much at all on an outpatient basis. And they are not in our formulary, and that's okay with me. Be aware of what you wish for. If you could prescribe them, then you'd have a problem, because people be coming to you wanting them. Okay? Interestingly, the benzodiazepines can, at the same time they are inhibiting, they can cause behavioral disinhibition. And why is that?
Like a rebound effect?
Nope.
That's the frontal lobe.
Yeah. But what does it do? Now think what's cross-tolerant with the benzodiazepines? Alcohol. So we know alcohol is disinhibiting in some people. And what is the mechanism there? It is the mechanism, the research indicates, is it slows down your thinking enough, it's hard to monitor yourself and interact at the same time. So you don't do self-monitoring as effectively. The second thing with the benzodiazepines, and the reason that they can be disinhibiting, is a lot of the reasons we don't do things is because we're scared to do them. And as soon as you take away somebody's anxiety, then they're not scared to do it anymore. And there are some people who have been chronically anxious all their lives, and they have never learned to inhibit their own behavior for reasons other than because they're anxious to do things. So take away their anxiety, and now they don't have any reason to not do anything. And so they may well act out. I had the most unfortunate situation of having a patient who was a wonderful grammar school teacher who had an early history of bulimia. And she had been treated for that with inpatient therapy and was stabilized for 15 years. She did well and was not binging and purging, managed it. She still had she had engaged in self-management. And she was just an incredibly, really just a lovely person. Exactly the person you'd want to have your children taught by. And she was fearful of flying. And her primary care doctor gave her 7 Xanax so she could fly there and fly home. And the Xanax reduced her self-monitoring to the level that she binged and started binging and purging. And it took 5 years for her to get back on top of that cycle of binging and purging. And that was the Xanax effect simply disinhibiting her. And so one of the things we have to remember about these benzos is that rather than somebody being calmer and more relaxed, they may appear energized and act out. You and I don't cause harm to other people, not because we're afraid to, but because we're way too empathic. One of our major flaws is we're so empathic that we just bleed with other people. So the last thing we want to do is ever hurt anybody. But some folks are so anxious that their self-control is simply driven by being so anxious that they're almost frozen chronically. Take away their anxiety, and they've never experienced empathy as a reason to put a brake on their behavior, because the brake has always been anxiety. So you can create a monster. You can actually take someone who has been a chronically anxious type person and disinhibit them with benzos, and they may well end up doing pretty destructive things to themselves and other people. Okay. You get additive effects, synergistic effects with ETOH, additive effects with some other substances, cognitive impairments, withdrawal phenomena. And remember I said that the withdrawal syndrome from the benzodiazepines is one of those that is actually possibly fatal. So we don't just take somebody cold turkey off of a chronic maintenance dose of benzodiazepine. First, it really doesn't work, and secondly, they could seize. The common dosage ranges are here. Okay. Here are the pregnancy categories for the benzos. Here's another reason not to prescribe it. They're Ds. Now this is potency and half-life, and indicating something about the abuse potential. Alprazolam Xanax is short half-life, high potency, and so therefore it is pretty addictive. Lorazepam is high potency, but not so short half-life, less addictive. These are, usually they are the dosage, the industry standard for you compare them to, what do you compare them to? 5 milligram of diazepam, Valium. Since Valium's been around long, you're saying how much benzo of the other benzodiazepine does it take to be equivalent to 5 milligram of Valium? And this, let's see, is that have it on there? Yeah, the equivalency here is with 5 milligram of Valium. And a half milligram of Xanax is the equivalent of 5 milligram of Valium. Okay? So it may give you the impression somebody's on a whopping dose if they come in on 10 milligram of Valium, but that's only, a milligram of Xanax. Now, the pharmacotherapy for anxiety, this is the chart. And I think, did I teach you folks about anxiety? Did I teach that weekend class? What is that about cognitive dysfunction in the elderly? I don't remember. Taught somebody. I must have been the FDU people. Okay. For panic disorder, GAD, social anxiety, and PTSD, these are in descending order, sort of what would your first choice, follow-up choices be. And notice that for all the anxiety disorders, the first choice is an SSRI.
So, surprised Wellbutrin wasn't in that anyway.
Let me see. Well, it's not anxiolytic at all.
Oh, I was thinking.
Yeah, no. It's not anxiolytic. It doesn't help with anxiety. It really doesn't.
I'm surprised that duloxetine though is third.
Well, why would that be? How is duloxetine different from venlafaxine?
I guess they're both SNRIs.
But how are they different?
Longer.
What else? We're wondering why duloxetine would be listed as less effective on anxiety than venlafaxine. Something besides the half-life and the name. Duloxetine has a better balance, an almost even balance between serotonin blockade and norepinephrine blockade. Venlafaxine is biased in the direction of more serotonergic blockade and less norepinephrinergic blockade. So duloxetine is going to be a little more activating and a little less anxiolytic than is venlafaxine. Okay? Acute versus chronic. Chronic rely on antidepressants rather than benzos unless the antidepressants counterindicate. Now, I'm going to tell you a secret. Don't tell anybody. The first 2 weeks you put somebody on an SSRI, they're activated. And if somebody's got an anxiety problem, they're going to feel worse for the first 2 weeks if you put them on an SSRI. So what I do is start an SSRI, I do this sometimes, and give them 2 weeks only BID dosing of clonazepam, 0.25 milligrams. And what that does is treat the immediate activating side effect of the SSRI. But I tell them up front, this is all you're going to get of this medication. And you won't need it after 2 weeks. And the truth is, most of the time they come back and they don't take all of the clonazepam. They don't need it once the SSRI kicks in. So I will use it temporarily to suppress the
I
side
do that
effect.
with Wellbutrin too?
No.
Isn't that more activating?
Yeah, but it's never going to be anxiolytic, so I'm not treating anxiety with it. I do that just with the SSRIs.
But there's some people, a lot of people have depression and anxiety. So if you give someone Wellbutrin for the anxiety, for the depression, would you also want to give them something like that?
Yeah, a poor man's MAOI. A poor man's MAOI is increasing serotonin, norepinephrine, and dopamine all at the same time. So how do you do that? 2 medications, an SSRI, and bupropion. And then you've done what an MAOI does, which is increase all 3 at the same time.
Except that you're not sensitive to diet and stuff like that.
That's right. So that is a rational dosing strategy.
They are. Was it Brintalex or what's the new med that does that?
Oh yeah, and I forget what it is. It won't be all right. And it costs $1 gazillion.
Of course.
I'm not going to use it for years until it's generic, and then it may as well just prescribe the 2 together. Okay. Benzo withdrawal. Look at those half-lives. Here are the symptoms. Why would psychosis be a symptom of benzo? Well, psychotic symptoms happen anytime our brain is overexcited and not working well and not filtering well. And so you've just increased it, you've imbalanced the brain in the direction of glutaminergic excitation. So your brain's not going to be working real well, and you may have an episode of what is delirium. It will look like a psychotic episode. And it won't go away real fast until you get down-regulation in those glutamate channels. And that may take a little while. Attention enhancers. Sympathomimetic amines, dopamine agonists, promote the increase of catecholamine neurotransmitters at the CNS synapses, dopamine, norepinephrine, and epinephrine. The exception is atomoxetine. And what else now that increases norepinephrine? Guanfacine is a bad antihypertensive that actually increases norepinephrine. And so guanfacine is cheap and dirty Strattera, which is more expensive. So here are trade names, generic names, what they are approved for, memory enhancers. Increase acetylcholine in the hippocampal area. Set the decline clock back about 2 years. There's no way we have thought of yet to replace the neurons that are being destroyed or lost. Aricept, Tacrin, Rivastigmine. I think it's only now, is Tacrin still available? Somebody look in, would somebody look in Hippocrates to see if galantamine and Tacrin are available still? Casey's typing. So what's the answer?
What was the question about galantamine?
Galantamine, is it available now?
It's on Hippocrates.
Okay, it is still available. What about Tacrin, Cognex?
I don't see that.
Okay.
You tried,
I was thinking one of them had dropped out, and I couldn't remember which one. The most often used is donepezil, and then memantine. And memantine is an NMDA antagonist. And what does that mean it does? Blocks NMDA. NMDA is excitatory. Take too much of that, you're gonna go wacky. And it does that by increasing glutamate transmission. So what you're doing with Namenda is inhibiting glutaminergic excitation of neurons, thus protecting them from damage from glutamate overexcitation. So that's why Namenda memantine is called neuroprotective. In the same way, actually lithium is neuroprotective. And what does it do? Remember, the mood stabilizers, the anticonvulsants, all to some degree are neuroprotective because they are protecting the neurons from overexcitation and therefore damage due to glutamate overexcitation. So we often prescribe memantine in combination with donepezil. So we're trying to protect whatever neurons are still left there, as well as soup up the cholinergic neurons that are there in the hippocampus in order to increase memory function and memory retrieval.
Casey's asking, Dr. Hoover, do you ever have difficulty diagnosing dementia? It seems it can be a great deal of assessment to differentiate between age-related cognitive decline, cognitive impairment versus dementia.
Yes, well, that's something you're asked to do all the time if you're a prescribing psychologist in a medical setting. And difficulty, I suppose so, especially when you're expected to do it relatively quickly. So what do? We use things like the MOCA. We get a good history. We look at how quickly it came on. We find out about family biological history, and we make our best guess. And then we prescribe the medication to see if the symptoms improve.
do we prescribe those?
Oh, yeah.
Well, when I took the course, only Aricept was available. I think Namenda wasn't. Or,
Right.
So, and you told us the real evidence was if Aricept made any difference at all, it was maybe 60 to 90 days. And now it's being given like penicillin. So it seems like thousands of dollars are being wasted for a drug that might only, because I remember that discussion.
That's true.
And now Namenda is added on almost
That's
the
right.
same way. So there's no evidence long-term.
Well, what you do is set back the decline, and then the person still declines. So it's like you're taking this decline curve, and you're just bumping it out this way. Well, is there a value in doing that if you actually see a therapeutic effect that makes a difference subjectively in the life of the individual and objectively in the life of the loved ones and caretakers of the individual? Then there may be a justification because there's nothing else. But you also got to think about the fact that you're making the person wet because you're increasing cholinergic transmission. He's got to go, he's got actually an excused absence. He got his hall pass, he's carrying his hall pass right there.
See, Mike?
Let's see here. So that's one of those clinical judgments about, is there enough of an effect here that it is worth the burden and the financial burden and the cost? And so,
To me, here, seeing it with friends who are getting it like penicillin,
Yeah.
it's like an anti-anxiety drug, probably makes no difference at all in
Yeah.
cognition.
yeah,
And they know it.
then there's no point. And if it's not an Alzheimer's type dementia, then it shouldn't work anyway. You know, this only works in the kind of dementia that is caused by the loss of cholinergic neurons in the hippocampus. And so you're souping up the ones that are left there. If it's not that precise kind of dementia, theoretically it shouldn't work anyway. Yeah.
So you can't mask it. If you gave a medication, if it's not working, I mean, in this case, I just think that we say we're going to treat symptoms, but I think arriving at a diagnosis is important, and my understanding was that there's like tests, a long series of tests to be able to arrive at the diagnosis and to rule out other things. So it's not a different form of dementia.
Well, certainly you're going to try to rule out other causes.
Right.
But if the question is, how sure are you somebody has an Alzheimer's type dementia? Never. Until the post-mortem biopsy of the brain is the only time we're really, really sure that's what it is. And so this is at the level of, based on the best evidence, making an informed professional clinical judgment, and with the patient or the patient's medical decision maker with regard to, is there a point in doing this? Yeah.
And then there's the whole family history thing. You know, I've known almost entire families where elderly people have the same disorder, and you could see
Absolutely.
eventually then even physical deterioration and shutdown of organs.
Yes, yes, absolutely. So that may help you come to the conclusion. But diagnoses are always guesses anyway. Okay, weight management. Not done very much anymore. Hypnotics. You need to ask 3 questions. Is the person having difficulty falling asleep? Are they having difficulty staying asleep? Are they having, how much time for bed do they have? So the acronyms are SOD for sleep onset delay, DMS for difficulty maintaining sleep, and TFB for time for bed. So if they have sleep onset delay with no difficulty maintaining sleep and they've got 8 hours to sleep, then you just need something that will help them get to sleep. So a short-acting hypnotic. They don't have trouble getting to sleep, but they have trouble staying asleep, then either a longer-acting hypnotic without daytime sedation, or a short-acting time when they wake up, short-acting when they wake up early. So this is how you decide what kind of strategy to use. And Zalopon Sonata is the shortest acting. So if somebody has difficulty with sleep maintenance, but no difficulty getting to sleep, then you could give them Zalopon to take only when they wake up and can't get back to sleep. If you try to get back to sleep for 20 minutes and can't,
and you have at least 2 more hours to sleep, well then take the Zeta block. And if they have both difficulty getting and staying asleep, and they have 8 hours to sleep, then you can give them an extended release hypnotic. You don't want to give them anything with daytime sedation. And then you use the short acting or shortest acting if they have less time to sleep. And certainly if they don't have much time, 2 hours or so, you're going to use Sonata Zeta block.
Might as well skip it at that point.
Well, yeah, though people will say, you know, I only get 4 hours of sleep, I wake up and then I'm awake and toss and turn for 3 more hours and I'm fine, you know. Well, there, they can take it and then they get a couple more hours of good sleep and they feel better. These are benzos that are used. We don't use those anymore for sleep. And there's a lot of folks who have acted out on hypnotics. And they have blackouts like with alcohol where they're up functioning, doing things, and they don't remember it the next day. The non-benzos, these are the Z drugs. We just talked about those. And notice the pregnancy categories for anything other than the Z drugs are C's, are X's. The Z drugs are C's. And so is Rosarum Romeltion. How does it work? How does Romeltion work? That is in your formulary. It is a sleep drug. How does it work? It works less well than this lecture in getting you to zone out. It is a melatonin agonist. So it's just like taking melatonin. And I actually had people, back when I first was prescribing and before I shut down the drug reps coming in and giving us samples, we had samples of Rosarum. I gave Rosarum to a patient and they brought it back to me half empty and said, this stuff doesn't work. And it is seldom used because it is not very effective. You may as well just take over-the-counter melatonin rather than spending money for Romeltion. Okay. Let's see. Sedating antidepressants, trazodone, doxepin, mirtazapine. We talked about those before. Over-the-counters. What is Salmonax? Almost all of those are an over-the-counter analgesic mixed with Benadryl. So the active agent for inducing sleep in the over-the-counter sleep agents is largely Benadryl mixed with some sort of an analgesic. Tylenol or acetaminophen, Tylenol, or acetylsalic acid, aspirin, COX-2 inhibitors mixed with Benadryl. That's what the over-the-counters typically are. And then we're not going to use barbiturates, hypersomnia, excessive daytime sleepiness. And what do you do for that? Modafinil. You can use selegiline and stimulants. Coffee. Adenosine inhibitor. Adenosine phosphate inhibitor. So that's the crave sleep hormone. That's the one where you just have this craving, this such an appetite for sleep. That's adenosine dump. You block that with caffeine. But it only blocks it for how long? 2 to 3 hours.
Yeah, a few hours.
Then you're going to keep dosing yourself.
But we were talking about, Gabe found in the book where it's still just a general stimulant too. Caffeine is. It doesn't just.
Oh, that's right.
It doesn't.
It's also dopaminergic.
Yeah.
Now, it's baby cocaine. Caffeine is baby coke. Yeah. So it blocks adenosine and gives you a high at the same time. Hey, it's baby cocaine. It's baby meth.
Because I forget, do you remember who that he said it didn't help with ADHD.
Right, because
But-
it's the same.
Right, but probably not the same way, but it did affect the same area in the.
It does a little bit.
Yeah.
Yeah, it does a little bit with ADHD. Yeah. Oh, yeah. Well, it helps concentration, focus. Yeah. Okay, substance abuse treatment. Okay, we're going to, how many more slides in this section? You know this stuff the most, and how many, it's only about 100 left, right?
Only
75, I think.
Only about 100.
Oh. Okay, so let me see what else kind of stuff is in here, a bunch of stuff. Nicotine replacement. Remember nicotine replacement?
Can we prescribe nicotine?
Oh, yeah.
Nutrients known for that.
Sure.
Other ones, yeah.
Patches, I'll prescribe patches. Really? It's pack of dependence is in the DSM, isn't it?
Huh. Yeah, you know.
Well, then it's in your formulary. Okay, alcohol, disulfiram, I have prescribed it.
But that includes the extra.
Ampral works better than, it actually works better than placebo for alcohol. Chantix works better than placebo. Too much stuff to get into there. TBIs, talked about those before. Concussion. Donepezil, what are we doing with Donepezil? So, all the 2010 up-to-date said Donepezil, Aricept helps in preliminary studies with more severe traumatic brain injury. Well, you know, you got to follow up on that to find out whether that's really true and who did the study. Was it the company that produces Donepezil? The only time, by the way, to really believe results of pharmacology efficacy studies if they are what? Yes, but how many of them? It's the meta-analyses. The standard of care is meta-analyses. And where do you go to see what resource gives you meta-analyses? A little louder.
The Cochrane Review?
Cochrane. You all are familiar with Cochrane?
Yes.
Okay. Okay, let's see. We've talked about all that stuff before. And some of these are repeat slides, actually. I accidentally clicked a bunch of repeat slides in here. So we're going to go to section 9.
Marlon, before we could go on, can I ask a question about, I saw that in this slide deck, testosterone is briefly discussed, I believe, for being prescribed for lack of sexual desire, interest, drive. You know, with working with a younger population of males, I've seen a lot of them take these testosterone supplements. Kind of how does the, so someone is taking these testosterone supplements, do we need to be aware of any particular drug interactions or problems prescribing them, anything else? And do those testosterone supplements even work?
They don't work in the way, usually, of increasing testosterone. They are, many of them, hepatotoxic. And they have, some of them have yohimbe in them, and what is it? Goat's ear, goats, something or other. There are a number of natural substances that are included that are in fact hepatotoxic. And so, no, they don't really increase testosterone levels. What might increase testosterone levels is DHEA, which is part of a one of the rate limiting steps in the production of testosterone. And however, there's no substitute for testosterone if you have too little testosterone. But there are some fairly serious concerns about testosterone supplementation in terms of cardiac effects, and potentially tumors, the growth of tumors that have testosterone sites on them. So prostate cancers, metastatic prostate cancers, you may in fact really induce very rapid growth of prostate cancers with supplemental testosterone. And so what is it? It's never smart to mess with Mother Nature. What is that old commercial?
Not nice to
It's
fool
not-
Mother Nature.
It's not nice to
Fool Mother Nature.
fool Mother Nature. But here's another example. That as we age, testosterone levels do drop over time. And so you can get norms by age in men for testosterone levels. But it's not clear that it's safe. And there are all these anti-aging studies, anti-aging centers for men where they give you supplements including testosterone. But I know physicians who say, older male physicians who say, I sure wouldn't take it, knowing what I know. And so I would caution young people, young men who are taking those over-the-counters. There's MaxiCut and Hydroxycut and a bunch of stuff that people take to try to increase muscle strength. And most of those combinations are either exploiting the connection to the amphetamines, which can cause cardiac problems, or they may, if they're effective, basically have naturally occurring production of pseudoephedrine in it, which can give you a stimulating effect. But the problem is, oftentimes they are hepatotoxic. So there are resources for over-the-counters to tell you what over-the-counters are safe and which are not, and what to look out for. And yes, you really do need to know what supplements somebody's taking and take that into consideration. Consumer Reports, the most recent month, has a list of over-the-counter supplements, the most common ones, and the potential hazards, benefits and hazards. But there's also a website, and I think, actually, I've given you a bunch of supplemental materials, and on one of the supplemental handouts is a list of links, and one of those links is to the website like Hippocrates, but it is for over-the-counters. So you can, when you go through those materials I gave you, the supplemental materials, you can find that link on that. You can actually get an app to download it into your, so you can look those up on your smartphone also.
Thank you.
And I should say, please do look through all of those supplemental materials I gave you, because they either give you additional connections for resources, or they give you supplemental information about topics that are important to know on the path. Okay? So that's why I included those additional resources for you. So take some time to just look at each one of those and see what's in it. And there's one that is 2 pages of just links to things that you may really find useful and want to boot up. Okay? Okay, research. Knowledge of pharmacological retrieval systems and databases. There are links. More links. Journal Watch Psychiatry I subscribe to, as well as Carlat. research design. You know about most of these. Random control trials, you know about. One of the things that's different for medical research and publication from psychology research is you seldom see individual case reports published in psychology. You see that all the time in medicine. You can get a refereed journal publication out of describing a single case. And so what we in psychology read off as anecdotal may be, here's a case that raises the possibility that there may be something going on here. So it might well be followed up on. So they use both single case reports and then a series of cases describing those cases, as well as then including some kinds of controls, non-parametric type research, so they match the cases with comparable individuals without the condition being illustrated, and then cohort or cross-sectional studies, and finally the industry standard, which is randomized controlled studies, and then a meta-analysis. And this is according to what the psychiatrists say. This is a hierarchy of evidence. And notice at the top, 1A, and those letters are used when recommendations are made, those letters are used to indicate what is the level of evidence. So a 1A is a standardized review of randomized, so it's not even, it's a review of randomized clinical trials. And 1B is individualized randomized clinical trials. And look at the bottom, is expert opinion. Okay, that's what the psychiatrists are being told about the quality of evidence in psychopharmacology. Now, how does the thing that is different and that you may not know about the research, this would be something you wouldn't necessarily know unless you studied it, is you probably never studied, okay, what are the steps in drug development that the FDA goes through? The first is phase 1, phase 2, phase 3, phase 4. This is when it gets to the phases that are the human pharmacology. Before that, there are steps. The statistics that may be new to you would be the relative risks and odds ratios are used more often in medical literature. The statistics are very familiar to you. Meta-analyses, again, that's when we get serious about thinking we know something, is when we have a meta-analysis that includes a number of random controlled trials that are really well controlled. And so to clear a drug, first are animal studies that are simply studying the acute, the subacute, and chronic toxicities. The second thing is to determine the therapeutic index. And the third is to look at pharmacokinetics and metabolism, to study how is this lab rat metabolizing and excreting this medication. And then there's a measurement, there's studies to evaluate the lethal dose. So what dose does it take to kill half of these lab animals? Don't mention this to anybody, but that's how we find out. What are the symptoms of toxicity? And this uses 3 different species that are human analogs. Then measuring subacute toxicity, usually giving it to them orally if that's going to be the route of administration. Several dose ranges, including what is the expected to figure out what is the expected range and then what are larger than expected dosages. And then perform labs on those animals to determine the impact on their blood, on their kidneys, and on their livers. And then there are chronic studies that last for several months of administering the medication, administering it to pregnant lamb animals to look for teratogenic potential, using multiple analogous species where the therapeutic index is calculated. All that's done before human beings are exposed to this medication. Then we have phase 1 in the preliminary pharmacological evaluation, and phase 2 is controlled clinical, phase 3 is extended clinical, and we're all in phase 4. We are all participating as psychopharmacologists in phase 4 of monitoring these medications for the FDA. And phase 4 is post-marketing surveillance. And we have a website and we have a phone number that if we have a patient on a medication and if they pop up any weird symptom, we are to report that. Because that's often how we finally discover that particular medications have undocumented side effects. In phase 1, you're starting with human beings. You've already calculated in animals that this medication is tolerated at a particular dosage. And you know about the impact on pharmacokinetics. And you know what it does to the liver and the kidneys. And so it's determined to be what the dosage range that's safe, that is not going to kill organisms that are human analogs, has been already established. Then you give it to healthy individuals, healthy adults, adult human beings. And the point of it is to look for toxicity in them, to figure out what is the optimum method of administration, figure out what the safe dosage range is, and to evaluate with lab studies, continuous lab studies, absorption rates, metabolism, and excretion of the medication. And this is in healthy adult volunteers. Are you really a volunteer if you are paid? Well, there are people, actually there are college students who volunteer to go to NIH and be part of drug trial samples for phase 1. Phase 2, once it passes phase 1 and it's determined to be safe, and the dosages are safe and we know what level to prescribe it at, then you use a proposed patient population, 1 to 200 people, doing blind and double-blind studies, comparing it to a placebo and another active drug or both. So if you're going to bring a new SSRI online, you would probably include both a placebo and another SSRI, standard SSRI, in comparison. And any adverse effects are to be reported to the FDA immediately, and they oftentimes shut down trials at that point. Then phase 3 is large-scale clinical trials. Prolonged duration, supposedly greater than a year. They'll leave 1,000 patients selected because they fit a particular category. And there's efficacy evaluated with chronic use and the risk-benefit analysis. Now notice that a lot of drugs, they don't get to be, they're not administered for the entire year. Data from the first 3 phases are compiled into an FDA new drug application for marketing approval. And then in phase 4, which we're all in, the drug's marketed and studied. We report, all of us are supposed to report to the FDA if our patients pop up with any weird symptoms on a psychotropic agent. We're supposed to let the FDA know that. Okay, knowledge of sampling, you know about all this stuff. They may ask you about IRBs. What are institutional review boards? What is something about the composition of the membership of institutional review boards? And remember that they usually have non-professional community members participating in deciding about experimental trials. And then regulatory issues. Who regulates? And what are the regulatory bodies? Well, we know that we have ethical mandates both for research and for practice. We have FDA regulations. We have state regulations, institutional regulations. You know about most of this. This stuff you know about. This is standard research stuff. Now we're going to number 10. See, just by skipping 50 slides, we're going to get through these 80 slides. Area 10. Professional, legal, ethical, and interprofessional issues. This is 7% of the exam. Examinees don't have trouble with this section. Ethics, standards of care, laws, regulations, relevance to the practice of psychology and involving psychopharmacology. Here are various groups that have established standards. Anywhere you're working, you're probably going to, if you're with an institution, you're going to have to deal with the Joint Commission. We have both our divisional standards, Division 55, the APA standards, and state ethics codes, which usually mandate that we follow the APA ethics codes. Joint Commission, the CAMAC, CMAC, state regulations, standards of care. Now, you have a defense if your practice demonstrates that what you did meets the standard of care. And we don't have standard of care in psychology guidelines for management of psychotropic medication. However, the American Psychiatric Association does. And whose standards do you think you'll be held to when you're in that witness stand and questioned about whether you did what meets the standard of care in managing a psychotropic medication? It is the American Psychiatric Association standards of care protocol. So it's a good idea to get familiar with those, because that's the standard by which you will be measured if you are on a witness stand trying to explain what you did. You are not expected by physicians to have patients never experience adverse effects of the medications. Remember that those side effects of medications are known effects that are to a large degree unpredictable. The more common ones are predictable in their presence. The less common adverse ones are much less predictable, but they are known. There is no way to practice without having your patients have side effects that are problematic. So if you're going to practice, it's going to happen. The question is not, did your patient get a side effect? The question is, did the patient consent to the trial of this medication with the knowledge of the potential of side effects? And did you due diligence set up a mechanism for them to easily report side effects and have those treated or ameliorated? So you have to meet the standard of care in appropriate information, informed consent, and caution, and then you have a defense. You never promise a patient they're not going to have side effects. And so the question is, did you do what is the standard thing to do in ensuring the safety of the patient as best you could, given the fact that they were taking on risk by being exposed to a medication? Okay. My throat hurts so bad, I'm tired of talking. I'm going to say one or two other things. You'll learn how to write prescriptions. You don't have to learn that right now, but basically a prescription's got to have the name of the medication, the dosage, how many, and how to take it, how many refills, and your name. And you only need to have your DEA number on there if it's a controlled substance. So I don't have to have my DEA number if it's fluoxetine. I only have to have it on there if it's a stimulant or a benzo. The patient's name has to have their date of birth, doesn't need their address. Otherwise, people without addresses can never get medication. Everybody has a date of birth. Not everybody has an address. And so I'm going to stop. And I'm going to thank you very much for your attention. I will sit here a little bit. If you have questions, I'll try to answer those.
Thank you very much.
Let's see if people out in TV land, do they have?
I have one question.
Yes, sir.
On the slide about lithium, it said it took 1 to 2 weeks to take effect. I was under the impression that lithium had an immediate effect if it was given.
A little bit, but you're not going to get, remember, you got to take 6 doses before you get a blood level.
Okay.
And so, and if you're dosing it twice a day, 3 days, you're not going to have a steady state until after 3 days. And so you're not going to really expect any dynamic effect due to that dosage until after 3 days. So that's why they say a week. You know, you got to get to the plateau, and then how are they going to respond to that over 3 days? That's a week. So that's why it says 1 to 2 weeks. You're going to check the blood level in 1 week because it will achieve steady state, and you have 3 days to make sure it's steady state. Then you know what is their serum level going to be with that dosage.
So if you come across a patient who's having really an extreme manic state to the point where they're physically out of control or even psychotic, would you handle that then the same way you would with a